Hello students, I am Dr. Manisha Buddhiraja, your Marrow faculty for ENT, and today we are going to do a very important session, that is the image-based discussion of ENT. So the image-based questions of our exams mainly follow two patterns. The first pattern is where the image is given just as a spot diagnosis. So there, if you know the image, that's wonderful, you can just answer it. But if you do not know the image, there is no need to panic. Yes, so always, almost always, the rest of the choices you will be knowing and you will be able to rule out what the answer is. And in the second set of images, it is a clinical stem, a clinical scenario that has been given along with the image. Now, in those type of questions, please do not immediately jump on seeing what the image is before reading the question. You have to read the clinical stem first. Once you have read the question, you will have the diagnosis in your mind already, and then the image will help you further that yes, this is the diagnosis, right? So do not do it the opposite way. And in many of the questions, you will see that once you have read the clinical stem, you even do not need the image. So there is nothing to fear in image-based questions. Now in this session, I have kept all those images which have been asked in the recent years in NEET as well as in INI set. Yes, I've also kept the questions which you repeatedly keep asking me, and also the potential questions which can be asked in the future. So let us start with this session. So let us start. The first question, yes, this is a spot diagnosis. Name the bone. So yes, we know it is either the malleus or the incus. Which one? So always remember that malleus has a head, so it has a neck also, and then it has a lateral process which goes towards the tympanic membrane, that is laterally. Anterior process which goes towards the anterior wall, and then it has a handle. Whereas in the incus, we have no head, no neck, directly a body from which arises the short process going towards the posterior wall and a long process which ends in the lenticular process which articulates with the head of stapes. So what we need to recognize is that these processes, consider them as limbs, and limbs always arise from the body, limbs never arise from the head, which means that if we are seeing limbs arising from the uppermost part, as here, it means this upper part is not the head. What is it? It is the body. And which ossicle has no head and no neck, directly a body? Yes, incus. So yes, this is how we are remembering. This is incus. Now coming to the next question, again a spot diagnosis. So what is the type of synovial joint? So yes, this synovial joint between the malleus and the incus, this is a saddle type, as we can see here. Whereas this joint between the incus and the stapes, this is a ball and socket type of synovial joint. Again, we need to remember that this area of the articulation of the incus with the stapes is the area with least blood supply, because of which is the ossicle to get necrosed most commonly? Very good, that is the incus. Please tell me exactly which side. Yes, the most common site is the lenticular process, this area, the lenticular process of the incus, followed by next most common is the long process of the incus. So the next question, mark the following as true or false about the given picture. And what we are seeing is the tympanic membrane, and the incorrect choice there was, it is the left tympanic membrane. So yes, this is very important. We need to identify which tympanic membrane it is. How do we do that? Yes, so always consider the tympanic membrane as a clock and the handle of malleus as the long arm of the clock. What we need to see is the upper end of the handle of malleus. If it is pointing towards the right, then it is the right tympanic membrane. If it points towards the left, then it is the left tympanic membrane. So on this tympanic membrane, let us see. So this is the handle of malleus. It is pointing towards, yes, the right. So this is the right tympanic membrane. also whichever side the upper end is pointing, upper end of the handle of malleus, that is the anterior part of the tympanic membrane. Is that clear? So you must be thinking that we are seeing the cone of light and we know it is present in the antero-inferior quadrant. So we know which is the anterior part. Okay, very good. Tell me, in this tympanic membrane, which is the anterior part? Yes. So when there is a perforation, we will not see the cone of light. So now can you tell me which is the anterior part? Yes, this is the upper end of the handle of malleus. So again, this is the right tympanic membrane and this is the anterior part and this is the posterior part. Why do we need to know that? Yes, the moment we know that this is the anterior part, if we are seeing some structures through the perforation in the middle ear, we know that we have to think of only those structures which are present in the anterior part of the middle ear. Whereas we know that most of the important structures of the middle ear lie in the posterior part. So whenever we are seeing any structure through the perforation which is lying in the posterior part, we know that we do not need to think about the eustachian tube which is on the anterior part. What are the structures we have to think of? We know they will be present in the posterior part. So for example, let us see this question. Yes, this was a question for exam. The structure marked by the black arrow in the given picture. So we are seeing certain structures in the middle ear. So first thing we need to know is these structures are present in the anterior part or in the posterior part. So how do we do that? Yes, this is the handle of malleus, this is the right tympanic membrane and this is the anterior part and this is the posterior part. Okay, so now what are these structures? Yes, so I will mark many structures here and you will tell me what these structures are. Okay, tell me one, what is this? Very good, the handle of malleus, the lateral process of malleus. Okay, now tell me 3. What is this opening that you will think of? Yes, in the anterior part, will you think of oval window, round window? All these structures are present in the posterior part of middle ear. So no, in the anterior part, if something is marked, we will think of, very good, the eustachian tube. Okay, now come to this. Tell me in the center, what do we have this? This I will mark as 4. Very good, this is the promontory. Now we will come to the posterior part. Always remember all the important structures are in the posterior part. So now, yes, tell me what is 5? What is 5? Yes, so this that we are seeing is something that is going in the vertical orientation. Yes, malleus and incus both go in the vertical orientation, whereas stapes is present in the horizontal orientation. So yes, this that we are seeing, the 5, this is, yes, this is the long process of incus and here this is its articulation with the stapes. So this here is the stapes. If this is the stapes, can you tell me what window is this? Very good, this is the oval window and below this, what is this window? Yes, that is marked by the second black arrow. Very good, this is the round window. So this was absolutely clear. Now let me ask you, can you see some structure coming from posterior wall? Yes, we know this is the anterior part and this is the posterior part. So if this is the posterior part, this will be the posterior wall. So can you see some structure coming from the posterior wall attaching to the neck of stapes? Very good, that is the stapedius. So we can also see the stapedius muscle, the stapedius tendon here. And from where it is arising on the posterior wall, can you see this pyramidal eminence? Yes, that is what is the pyramid. So when you know, your mind knows, your eyes will see. And now let me ask you, what is the structure marked by the white arrow? Yes, so we know that this is the oval window and this structure that has been marked here is something above the oval window. We remember our anatomy. We know that on the medial wall we have the oval window, above which we have the horizontal segment of the facial nerve, above which we have the lateral semicircular canal. So if this is going horizontally just above the oval window, what is this? Yes, this is the horizontal segment of the facial nerve. Is that absolutely clear? Okay, so very good. So coming to the next question, A 5-year-old child presents with reduced hearing for the past 2 to 3 months. Most likely diagnosis is. So yes, this is a clinical STEM question, and whenever we are seeing image in a clinical STEM question, first try to come to a diagnosis by reading the question and then see the picture. So when we read this question, 5-year-old child, reduced hearing for 2 to 3 months. A child with the only complaint of decreased hearing for few months, what should come to your mind? Remember, this is the repeated question. Yes, what will come to your mind is serous otitis media. Is that clear? And with this in your mind, next you will see the picture, and yes, what you are seeing is bubbles. This you are seeing is the tympanic membrane, yes, the left, and you are seeing the bubbles on the tympanic membrane. That confirms, yes, it is serous otitis media. Why am I asking you to give attention on the question? Because in this question, the other choices were acute otitis media, myringitis bullosa, and some of the students said that the picture was very bad, so we confused it as bulle and we marked the answer as bullous myringitis. Now tell me, if it is bullous meningitis, if it is acute otitis media, will the presentation be a child with the only complaint that is hearing loss? Never. Whether it is acute otitis media or it is bullous meningitis, always there will be pain. The presentation is more or less the same. Only the difference is in the appearance of the tympanic membrane. Is that very clear? Yes. So now tell me, what is this first picture? What is this first picture? Very good. This is the cartwheel appearance of ASOM. Tell me the second picture. What is this? Yes, again, this is acute otitis media, the bulging tympanic membrane. Yes, this is the suppurative stage. And what is this third picture? Yes, this is a very red congested tympanic membrane. Again, it is full and bulging. Again, this is acute otitis media, the suppurative stage. Now tell me whether it is 1, whether it is 2, whether it is 3, whether it is hyperemic, that is the pre-suppurative, or it is the suppurative stage. What is the presenting feature of this child? Pain, and the pain is maximum in the suppurative stage. Now tell me this fourth picture, what are you seeing here? Yes, here we are seeing bulle on the tympanic membrane. This is bullous myringitis, but again here the presenting feature will be pain. Is that clear? Yes. Now see this picture, tell me, is this acute otitis media? We are seeing some red thing here. Yes, this red thing cannot be acute otitis media, which is a uniform red thing. Yes, here we are seeing the red thing localized to the lower part, the hypotympanum. So this is the typical appearance of Glomus jugulare, which is the red vascular tumor which comes from the floor into the middle ear, and this is what is known as the rising sun appearance. Now you will tell me, if this is the image that is given, what will be the presenting feature? Yes, mentioned in the question of Glomus. Very good, pulsatile tinnitus. Pulsatile tinnitus. Without pulsatile tinnitus, you will never think of Glomus, right? And always that presentation will be given in the question. So the next question, and this is something you repeatedly ask me, what is the grade of retraction? So first let us see what the grades of retraction are, and then we will come to this question. So the grades of retraction of the parts tensa are known as Sarday's classification, whereas of the parts flaccida are known as TOS. So on the top is pars flaccida, so you can remember that is TOS, and below is pars tensa, that is SAT, so it is Sarday's. So what is grade 1? Grade 1 is when the tympanic membrane is just retracted, it is not touching the incus. So how will we find that the tympanic membrane is just retracted? What are the findings of a retraction of tympanic membrane? Yes, the features are the cone of light is either absent or it is distorted, because of which the tympanic membrane appears very dull. And when the tympanic membrane is retracted, what happens is that the pulling of the handle of malleus occurs towards the inside, because of which the handle of malleus appears very short. That is known as foreshortening of the handle of malleus, which was appearing lengthened like this. Now it is appearing foreshortened, and also the lateral process of malleus will become more prominent. So now let us see what we are seeing in this tympanic membrane in the first picture. The second picture, is the normal tympanic membrane. Here just see the handle of malleus. Yes, now see in the first picture, can you see the foreshortening of the handle of malleus? Can you see that the lateral process is so prominent? Another feature of retraction is that the anterior and posterior malleolar folds will appear very sickled because of retraction of the handle of malleus. Now yes, always remember that all these features will not be present in all the retraction, but if any of these features of retraction are present, then we call it as a retracted tympanic membrane. And as the stages of retraction will increase, then we might be able to see all the findings in one tympanic membrane itself. So yes, this is how a stage 1 will look. It is nowhere attached to the incus. Now what is the second stage? Now in the second stage, the retraction will go more medially. More medially means it will go and it will touch the incus or it will touch the stapes. Both are present together, either the incus or the stapes. So when we look at the tympanic membrane, what we have to look here is whether it is touching the incus or not, which means which part of the middle ear are we interested here in? Very good, in the posterior part, because in the posterior part we will see the incus, the stapes. Is that clear? So yes, we will first see in this tympanic membrane which is the posterior part. Always it has to be a stepwise approach. So now this is the tympanic membrane. Yes, the handle of malleus. So this is the right tympanic membrane, this is the anterior part, this is the posterior part. So now let us see in the posterior part, are we seeing something? Yes, we are seeing this longitudinal. Yes, this is the incus, and also we are seeing here the articulation of the incus and the stapes. So what is this grade of retraction? Yes, this is the stage 2. Now let us come to this question. Yes, can you see what are you seeing here? Yes, so we have to see first which is the anterior and which is the posterior part. We definitely know that this is a retracted tympanic membrane. Why? Because the cone of light is so distorted. This tympanic membrane does not appear normal. So yes, this is the handle of malleus. This is the left tympanic membrane, this is the anterior part and this is the posterior part. Now let us see in the posterior part, are we seeing something? Let us magnify it a little. Yes, we are seeing some round thing here. Where is the incus? Can we see any longitudinal thing here? No, we are not seeing. All that we are seeing is this round thing. So yes, what is this in the posterior part? What can this be? This has to be the head of the stapes. Where is the incus? It is absent. Why? Because the most common ossicle to get necrosed is incus, and that has got necrosed here. So if it is touching the stapes, what stage is it? Yes, it is stage 2. Is that clear? So now coming to stage 3, stage 3 means the retraction will go more medially. So now when it goes more medially, where will it go? It will go and it will touch the promontory on the medial wall. When it touches the promontory on the medial wall, it means all the air of the middle ear is gone. And when all the air is gone, like in the lungs, what do we call it? Atelectasis. So here also we call it as atelectasis. So always remember, it is just touching the promontory. It is not adhering to it. The mucosa is not adherent to the tympanic membrane. So now what will we see here? Yes, so let us see on this tympanic membrane. Yes, this is the left tympanic membrane. This is the anterior part and this is the posterior part. What are we seeing here on the posterior part? Yes, we are seeing the incus. We are seeing the stapes, and can you make out it is appearing as if the incus and the stapes part, it is wearing a body hugging tympanic membrane. It is so clear, the incus as well as the stapes. And also, where are we going to find the promontory? Yes, just see the promontory. Is it also appearing as if the tympanic membrane is draping on it? So yes, this is how a grade 3 will appear like. This is 3. And what is 4? In 4, the tympanic membrane is not only touching it, but it is adhering on the mucosa of the promontory. So this is what is known as adhesive otitis media. Now let us see this tympanic membrane. What is the first step? Yes, always follow stepwise. Yes, this is the right tympanic membrane, this is the anterior part, this is the posterior part. Yes, in the posterior part, what are we seeing? Can you make out? Again, we are seeing this round. What is this? Yes, this is, you tell me. Very good, the head of the stapes, which means what is missing here? Again, the incus is necrosed here, missing here. And what is this? Tell me. Yes, this is the promontory. This is the promontory area. This is even the round window we can see so clearly. So yes, this is the stage 4. Now, I know what you are thinking. You must be thinking that whether it is stage 3 or this is stage 4, we are confused. We are not able to exactly make out whether it is 3 or 4, because in both of them it is touching the promontory. Exactly. You will not be able to make out just by seeing whether the tympanic membrane is just touching the promontory or it is adhering to it. How can you make out? You will be able to make it out whether it is stage 3 or stage 4 only by a Seagull speculum. So you will put the Seagull speculum, you will increase and decrease the pressure of the external auditory canal to see whether the tympanic membrane is mobile or not. In stage 3, will it be mobile? Yes, whereas in stage 4, it will not be mobile. So, which means that it will not be given to you as a picture base, whether it is 3 or 4. So, either something else will be mentioned, like it is adherent or it is just draping on the promontory, right? Okay. So, the retraction of the pars flaccida, the stages, we need not know how to identify your image. Yes, definitely we need to know theoretically, but on the image, the pars flaccida, that is the TOS classification, you need not know. All you need to know is that whenever you are seeing a retraction in the pars flaccida, let us see this image. What you are seeing here, we are seeing the pars tensa here. Can you make out? This is the handle of the malleus. Yes, and here we are seeing the retraction in the pars flaccida. Again, in the first picture, see this. This is the handle of malleus, there is the pars tensa, and we are seeing retraction in the pars flaccida with whitish cholesteatoma flakes. So, whenever you are seeing any retraction in the pars flaccida, not only the retraction, if you are seeing the whitish flakes, or if you're just seeing granulations, or you're seeing debris, anything that you're seeing abnormal in the pars flaccida, then what is it? That is a spot diagnosis. Then that is what cholesteatoma, primary or secondary? Very good, that is primary cholesteatoma that follows retraction pocket, the most common site of which is pars flaccida. Is that clear? So, see this question. Below is the endoscopic picture of a patient who presented with foul smelling ear discharge. This history tells you foul smelling ear discharge. Yes, it is squamous otitis media, which was more commonly known as unsafe otitis media. So, you know that what you have to look for. Yes, either the pars flaccida or the posterior marginal perforation. Most common, most probable diagnosis is. So, yes, see here. What are you seeing here? We are seeing the pars tensa. Can you make out? Only when your mind knows, your eyes will be able to see. Yes, this is the handle of malleus, and in the upper part, in the pars flaccida, we are seeing some dirty whitish flakes also, and some black debris also. So, yes, always remember, any dirty thing that you're seeing in the pars flaccida has to be primary cholesteatoma, and this has been a repeated question of your exam. So, this is primary cholesteatoma. The next question, following car accident, patient presents with the following appearance. It is known as, yes, this has been a repeated question. What are you seeing here? Yes, this is bruising in the post-auricular area, and this is the typical appearance of, very good, the petrous temporal bone fracture. This is known as battle sign. Excellent. Will you ever confuse it with the picture 2? What you are seeing in picture 2? Yes, we are seeing the congested edematous area, post-auricular area, which is even pushing the pinna forward. This is the typical appearance of, this is, tell me, yes, this is mastoiditis, mastoiditis. Yes, we can never confuse it with the bruising or the ecchymosis of the battle sign. The next question, this was a question this year. A patient presents with pulsatile tinnitus. A red mass was seen behind the tympanic membrane. CT is given below. What's the diagnosis? Yes, so always whenever we read the question, that is what we have to do first. We have the diagnosis in our mind, right? Pulsatile tinnitus means this has to be glomus. Yes, so in the diagnosis, we know it is glomus, but in the choices where glomus tympanicum and glomus jugulare both given. So, which means that we need to see the CT and find out whether it is tympanicum or jugulare. So, what is the area of interest? Where should we look for in the CT? Before that, let us see How to see a CT of the temporal bone? Now always remember that the ear, the whole of the ear is present in the temporal bone. So where is the temporal bone? Now in the first picture, yes, we are seeing the upper part of the temporal bone, the upper surface. So this here is the temporal bone, this is the squamous part, this is the petrous part. And in the second picture, we are seeing the lower surface of the temporal bone, and this here is the temporal bone, this is the squamous part, and this is the petrous part. The mastoid part is present posteriorly, right, in both. Now we saw the upper as well as the lower surface of the temporal bone. Where is the ear? The ear is present inside a tunnel in the temporal bone. Is that clear? So if we cut this temporal bone, upper surface is this, lower surface is this. If we cut in between, we will find the complete ear cavity. So which means if I draw the ear here, we will have the pinna here, the external auditory canal, the middle ear, the inner ear. Is that clear? Yes, and this here is the petrous apex. Now, see posteriorly. Yes, in this case of a glomus, we are interested in which area? Either the middle ear. The glomus tympanicum arises from the tympanic plexus on the promontory. So, either if we are seeing the CT, we want to see either the middle ear, or what we want to see is the jugular bulb area, that is the glomus jugulare. So what is the jugular bulb area? Yes, so now see carefully here. Can you see this foramen here? What is this foramen? Yes, this is the jugular foramen. The jugular bulb, what is that? That is an extension of the sigmoid sinus. See carefully, this is a straight sinus. This is a transverse sinus which becomes a sigmoid sinus. Yes, and this sigmoid sinus ends in the jugular bulb, in the jugular foramen becoming the jugular bulb. And this jugular bulb comes out. Now see the base of the temporal bone. This here is the jugular foramen area, right? So from here the jugular bulb comes out and it lies in the floor of the middle ear, right? It lies in the floor of the middle ear, which means that we want to see the tumor either in this area, right? That is one, or second, the tympanicum, that is in the middle ear. Yes, so if you know this, you will focus on these areas in the CT, otherwise you are totally lost. So now let us see how a HRCT of the temporal bone will look like. When we cut the temporal bone like this through the ear, this is how the CT will appear like, and this is exactly how I drew it. See now, it is so easy. This is the pinna, this is the external auditory canal, this here is the middle ear, this is the inner ear, this is the petrous apex. Is that clear? So we are interested either to see this area, that is the middle ear, or where is the jugular bulb area? Yes, this is the jugular bulb area. Is that clear? Okay, so now let us see the image that was given to us. So now is the CT making sense to you? What is our area of interest? Yes, it is either the middle ear or the jugular foramen. Where are we going to find it? So this here is the external auditory canal on both the sides. This is the middle ear containing the air, and this is the inner ear area. Yes, and this is the petrous apex. Petrous apex. Okay, so let us see in the middle ear. Are we seeing something? No, I don't think we are seeing anything. The second area of interest is the jugular foramen. What is the jugular foramen area? So this is the sigmoid sinus, and yes, this is the jugular foramen area. So can we see a huge tumor here in the jugular foramen area? So yes, this is a glomus jugulare. Now even if it is a glomus tympanicum, which is very small, and middle ear most of the time is so small to visualize, you might not be able to see. So you next see the jugular foramen area. If the jugular foramen area looks very good, then you can mark the answer as glomus tympanicum. Is that clear? Okay, so now coming to the next question. A 70-year-old male presents with left sensorineural hearing loss and tinnitus. On examination, there is loss of sensation of the posterior superior part of external auditory meatus. MRI is shown below. So whenever it is a question which says an elderly with unilateral sensorineural hearing loss, in elderly, what's the hearing loss we expect? We expect sensorineural hearing loss, which is presbycusis, and presbycusis is always bilateral. So always remember, as I told you, that a child with bilateral conductive hearing loss, what will you think of? Tell me. Serous otitis media. Similarly, any elderly with unilateral sensorineural hearing loss, what will you think of? Acoustic neuroma. Yes, and the loss of sensation in the posterior part of external auditory canal. Yes, this is what is known as Hitzelberger sign. Hitzelberger. So all this tells you this is a patient of acoustic neuroma. In fact, we do not need the MRI here. But still, if it is given, let us see what we are seeing here. So we are interested in the CP angle area. So yes, what we are seeing here is this MRI. So we are not seeing the petrous bone, but what we are seeing is this mass, which is, yes, like this, and then it is coming with the CP angle. So yes, this is the typical appearance of acoustic neuroma. This is known as the ice cream cone. This is the ice cream cone, and what this is telling you is that yes, this is a tumor of the CP angle, but this arises from where? It is arising from the internal acoustic meatus, and then it is coming into the CP angle, right? So the next question, a patient is brought to the emergency with the complaints of seizures, altered sensorium and headache. He has been undergoing treatment for chronic ear infection. Immediate CT scan was done. So again, what is the history telling you? It is a chronic otitis media, now with some complication. Yes, because headache, altered sensorium, seizures, they tell you that what is the complication? Yes, this is a temporal lobe abscess. And what is the CT? So again, we do not need the image here. But if the image is given, what are we seeing here? Yes, we are seeing the ring sign or the ring enhancing lesion in the temporal lobe area. So yes, this is the temporal lobe abscess, and this has been a repeated question. So that was so simple. So the next question, identify the part of cochlear implant marked. Yes, this was a question this year, and we are seeing that this patient has bilateral cochlear implants. What are the parts of the cochlear implant? Yes, the cochlear implant has external component and internal component. In the external component, we have the microphone, which picks up the sound impulses, sends it to the speech processor, which converts the sound impulses into digital signals, and then it transmits the digital signals to the transmitter coil, and this transmitter coil will send the digital signals through radio frequency to the internal component. Yes, what is the internal component? The internal component is what is known as, this complex is what is known as the receiver stimulator complex. Yes, can you see here? This here is the external component. This is known as a transmitter coil, and this here is the internal component. This is what is known as the receiver stimulator complex. Now both the transmitter coil and the receiver stimulator are placed together by magnets. So in the receiver stimulator, this center is the magnet, whereas in the transmitter coil, this here in the center, we have the magnet. Also, in both the transmitter coil as well as the receiver stimulator, we have antenna, which can send the impulses through the skin. So the antenna in the transmitter coil is this here. This is the antenna, whereas in the receiver stimulator, this round thing there, can you see? This is what is the antenna here. Okay, so now in the internal component, we know we have the receiver stimulator. This whole is the receiver stimulator, and this receiver stimulator converts the digital signals into electrical impulses, which are then transmitted to the electrodes. So which means that the next part of the internal component is the electrodes. So what are these electrodes? We are seeing two types of electrodes here. Yes, one of them, the one that you can see, is curled up like this. Yes, this is the one that will go inside the cochlea, in the turns of the cochlea. This is known as intracochlear electrode. So this will be passed from the mastoid into the middle ear, and then from the middle ear into the inner ear. Can you tell me which window? Very good, through the round window. Yes, it will be passed into the inner ear. Yes, where exactly in the inner ear? Round window is covered by secondary tympanic membrane. So that is how I asked you to remember. It connects the middle ear to scala tympani. So yes, it is placed in the scala tympani. Now the other electrode, as you can see here, this one is what is known as ball electrode, or it is known as reference electrode, or it is known as ground electrode, and it is placed away from the cochlea, as we can see here, in the temporalis muscle. And what is the function of this? It regulates the power consumption and the intensity of stimulation of the electrodes. So let us see what was the marked structure. Yes, we can see what is marked is the ground or the reference electrode. So can we make out the other parts also? So yes, we are seeing the internal component. This is the receiver stimulator, and here we can see this round. This is the antenna. This center is the magnet, and this electrode, can you tell me? Yes, this is the intracochlear electrode. Now coming to the next question, which of the following method of rehabilitation of hearing should be done in a child with atresia of both the external auditory canal? So when there is atresia of the external auditory canal, when there is external deformities of the pinna, so that you cannot use a normal conventional hearing aid, then we use a hearing aid which does not need to anchor on the pinna or in the external auditory canal. Yes, it anchors to the bone behind the pinna, and that is known as bone anchored hearing aid or BAHA. So which one is BAHA here? Can you identify? Yes, this is BAHA. What is 1, 2 and 4? Yes, so let us see them also. Yes, what is this? This is an ossicular replacement prosthesis. This replaces ossicles. Which ossicles does it replace? Now let us see the second picture here. This is the second picture. Now it has a flat end that comes on the tympanic membrane, and it has a rounded end, other end, that comes on the footplate of the stapes, which means that it is replacing which ossicle? From the tympanic membrane to the footplate of stapes, all the ossicles. So this is what is known as TORP or total ossicular replacement processes. Now let us look at the first picture. Here this flat will come on the tympanic membrane, and see the other end. Yes, the other end is socket shaped, which means that it will come on the head of the stapes. So it is replacing only the malleus and the incus. So this is known as PORP, or this is known as partial ossicular replacement prosthesis. Yes, we should be able to identify which is PORP and which is TOP. So now can you tell me which one is PORP and which one is TOP? Yes, the first picture is, yes, this is PORP, and what the second? This is TOP. Very good. So what is this prosthesis meant for? Yes, this is, we can see on one end is flat, so this will come on the footplate of the stapes, whereas on the other end it is curved like this, which means it will hold something. What? Yes, the long process of incus, which means that it will come from the footplate of stapes to the long process of incus. It will replace the stapes when we have done a stapedectomy or a stapedotomy. So yes, this is the processes that we use following stapedotomy in otosclerosis, right? And this is what is known as piston or stapes piston. This is most commonly made up of Teflon. And yes, what is this? Yes, this is BAHA. What the components of BAHA we need to know. So this is what is known as a titanium implant or the fixture. This is what is implanted in the skull bone. And above that is the second part, which is known as abutment. This connects the internal component, that is the implant, to the speech processor. So this here is the speech processor, which are of various designs. Now what does the BAHA do? It directly sends the sound impulses into the cochlea. So it directly stimulates the cochlea. It bypasses the external ear and the middle ear. So whenever we cannot use a normal conventional hearing aid, as in atresias of the external auditory canal or deformities of the pinna, or also whenever there is chronically discharging ears, we cannot use a normal conventional hearing aid, and also when there is a very big cavity, as in canal wall down surgeries, so that is when we use BAHA. Another important indication of BAHA is, what is it doing? Yes, it is stimulating the inner ear of this ear. Not only is it stimulating the inner ear of this ear, it sends the vibrations through the bone, so it is also stimulating the inner ear of the other ear. So if there is complete deafness of one side, single-sided deafness, Then in that case also, when we put the Baha in the deaf ear, it will pick up the sound from that side and it will transmit it to the normal cochlea. So that is again another indication of Baha. And yes, this is how the cochlear implant looks like, that we have already done in detail. Yes, so what is this instrument? Yes, very good. This is self-retaining hemostatic mastoid retractor. Yes, we use it in all mastoid surgeries. And what is this instrument? Yes, this is the instrument, you tell me. Yes, it is used for myringotomy. Myringotomy, making opening on the tympanic membrane, either to remove pus from it, that is in acute otitis media, or to remove fluid from it in serous otitis media. And in serous otitis media, we always put, when we do myringotomy, we always put, very good, a grommet. So this is how the grommet looks like. And tell me the type of incision for grommet insertion, that is in serous otitis media. Yes, so for serous otitis media, the incision is a radial anteroinferior incision. Whereas in acute otitis media, you tell me the side. Yes, it is a curvilinear or J-shaped incision in the posterior inferior quadrant. Also tell me, myringotomy is never done in which quadrant? Never in the posterior superior quadrant, because we have so many important structures there. Yes, now can you tell me what is this device? Yes, this is what is known as audiometer, by which we do this test, which is pure tone audiometry. So in pure tone audiometry, we give the patient sounds by air conduction as well as bone conduction. For giving the sound for air conduction, we use the headphone like device, and for bone conduction, we use this device which sits like a hairband behind the pinna on the mastoid. Whatever result we get according to the response of the patient, we plot it in the form of a graph which is known as pure tone audiogram. Yes, and this audiometer you usually confuse with this device. What is this? Yes, this is a tympanometer through which you do tympanometry, right? In audiometry, this is a subjective test. Whatever the patient tells, we record, we make the audiogram according to that, whereas this is, the tympanometry is an objective test. You just put the probe inside the ear of the patient, and whatever response is there, that comes automatically in the form of a graph. So you need not confuse whether this audiometer or this is a tympanometer, because wherever you are seeing tympanometer, along with that you will see this graph. Are you seeing? Yes, you are always seeing the tympanogram in the tympanometer. Is that very clear? So yes, so now we come to a very, very important part, and that is the pure tone audiometry. Yes, we should know how to read the audiogram. In earlier days, the audiogram was given and was just asked that this is conductive hearing loss or sensorineural hearing loss, but nowadays the pattern has changed. So let us see how the pattern is. Yes, first let us see how to read the audiogram. So yes, in audiogram what we are doing, we are testing the hearing of the patient in the various frequencies. Yes, so the frequencies that we are testing in the air conduction and the bone conduction are on the x-axis, whereas on the y-axis we are measuring the hearing loss in decibel. Right? Yes, it is hearing loss in decibel. 0 decibel means what? 0 decibel means that the patient's hearing is perfectly normal. It is equal to what we consider as the reference for normal hearing, which means he has 0 decibel hearing loss, right? Okay, so now the first thing that we should know whenever we are seeing an audiogram is which ear it is. So for knowing which ear it is, we have certain symbols, right? And these symbols, yes, we have to remember. Now always remember that right ear is marked in red, whereas left is marked in blue. Right is marked in red, and many of the times your audiogram is given in black, so only that will not suffice. We need to know what the symbols are also. So how do we remember? Air conduction unmasked of the right ear, R for right, R for round, right? Whereas for the left ear, it is a wrong. How do you remember that? Wrong cannot be right. Wrong cannot be right, so it is the left ear. Okay? Okay. Now for the air conduction masked, for the left ear, just take the 4 lines of the wrong and rearrange it in the form of a square, whereas of the right ear, it is a triangle. Now bone conduction symbols are very simple to remember. The bone conduction, B for bone, all of them are like brackets. right? Brackets, B for bone, B for brackets. And also what we need to remember here is which one is right, which one is wrong. Again, that is very simple. For the right ear, the bracket opens towards the right, whereas left ear, it opens towards the left. Same for the masked, bone conduction masked. So the masked, unmasked is like less than and more than bracket, and masked is like the complete bracket. Again, for the right ear, it opens towards the right, and left ear, it opens towards the left. And whenever there is any arrow in any symbol, it means that there is no response, right? Now with this knowledge, tell me that this audiogram that is in front of you, it is of which ear? Okay, red. So right ear, always confirm also with the symbol. So yes, we can see this. Yes, this is a bracket, so this is bone conduction, and opening towards the right, yes, this is the right ear, and this is R for round, R for right ear. Yes, this is the right ear. So the second thing that we need to see is whether this is normal or not. So what do we consider as the normal range of hearing? So up till 25 decibel, the hearing loss is considered to be normal, right? So up till 25 decibel is normal. So is this audiogram normal? Yes, this audiogram is normal. Also, one more thing you need to remember here is that what we are testing by audiometry is air conduction and bone conduction. So do you remember what is air conduction? Yes, now I am speaking to you. How are you hearing? The sound is going from the air into your external ear, middle ear, and then the inner ear, and then from the nerve to the auditory cortex, and you are hearing what I am saying. That is what is air conduction, which means that air conduction, the sound goes through the air and it is a measure of all the pathways, which means it is a measure of the conductive pathway. Conductive pathway means from the pinna till footplate of stapes, plus sensory pathway, that is the inner ear, plus the neural pathway. So it tells you about the whole pathway, the conductive as well as the sensorineural pathway. Whereas what is bone conduction? Yes, in bone conduction, we are giving the sound directly to the bone, which means it will directly stimulate the inner ear. And then through the nerve, it will go to the auditory cortex, which means that bone conduction is a measure of sensorineural pathway. Yes, is that clear? Now quickly tell me which is the common pathway for both air conduction and bone conduction. Yes, the sensorineural pathway, this is the common pathway. Whether the sound is going from the air outside or through the bone, it will go through the sensorineural pathway. So that's the common pathway. With this basic, now let us see the rest of the audiograms. Okay, so now tell me this. Yes, this is first, always stepwise approach. Which ear? Yes, it is marked in black. So this is round. Yes, very good. This is the right ear. Okay, tell me this is right ear what? Air conduction or bone conduction? Bone conductions are brackets. This is, yes, this is air conduction. So air conduction, second thing, is it normal or not? Up till 25 decibel is normal. So yes, this is air conduction, which is normal. If the air conduction is normal, what is normal? Air conduction is a measure of conductive plus sensorineural pathway. It means that this complete pathway is normal. So if this complete pathway is normal, it tells us that the right ear of this patient is normal. We don't need a bone conduction curve in this, right? Yes, now tell me which ear? First step, which ear? Which ear? It is, yes, this is the bone conduction of right ear, and this is the air conduction again of the right ear. Yes, you have to see both the curves whether it is of the same ear, otherwise you will mistake it, right? Sometimes they give one curve of one ear, other curve of other ear. Now second step is whether it is normal or not. Up till 25 decibel is normal. So in this patient, the bone conduction is normal. Bone conduction is normal means what is normal? Bone conduction means sensorineural pathway. So sensorineural pathway is normal. What about air conduction? Air conduction is decreased. What is air conduction? Air conduction is conductive plus sensorineural. So if the sensorineural is good, where is the defect? Defect is in the conductive pathway, right? So that is what you need to remember the moment you see the audiogram, and when you see that the bone conduction is normal and there is a AB gap of more than 15 decibel, then it means that patient has a conductive hearing loss. Is that clear? So the bone conduction will be normal and there will be a AB gap. Is that clear? Okay, so now coming to the next. Yes, now tell me in this, which ear? Yes, the bracket, that is the bone conduction of which ear opening towards the right ear, and round, again it is the right ear. Now what we are seeing, second step, normal or not? So up till 25 decibel, it is normal. Both are decreased. Yes, both are defective and both are equally defective. There is no gap between the two curves, means they are equally defective. They are equally defective means what is affected? The common pathway. What is the common pathway? The sensorineural pathway. So which means that the moment you see an audiogram in which both are defective and there is no AB gap, it means that it is sensorineural hearing loss. No AB gap. Okay, no AB gap and both are defective. Equally defective. Now coming to the next, yes, what are you seeing here? One is red, one is blue. Is it 2 ears? Let us check. So this is the left ear bone conduction of left ear, and this is again wrong, cannot be right. So it is left ear air conduction. Let us see whether it is normal or not. Up to 25 decibel is considered normal. So no, it is defective. Bone conduction is defective means sensorineural pathway is definitely involved. Sensorineural pathway is involved, so the air conduction will also be defective because that's the common pathway. But we can also see that there is an airborne gap more than 15 decibel here, which means that the air conduction is not decreased equally to the bone conduction, which means that there is an additional defect in the conductive pathway also. If the air conduction were decreased because of the common pathway defect only, because of sensorineural pathway defect only, then the air conduction and the bone conduction would be equally defective and there would be no AB gap. Right? So whenever you are seeing the bone conduction is defective and also there is a AB gap, it means that this is both sensorineural as well as conductive hearing loss, that it is a mixed hearing loss. Is that clear? Okay, so here, yes, here we are seeing both red and blue. So yes, both the ears, which means that this is some condition which leads to bilateral hearing loss. Yes, let us see whether there is hearing loss or not also. And whenever we see that, we will see individually. First the right and then the left. Now here it is more or less the same, so it does not matter. So yes, first let us see the right ear. Now right ear, yes, this is the round. Yes, this is the right ear. Now let us see whether it is normal or not. Yes, we can see that some frequencies are normal, the low frequencies are normal, but there is a defect in the high frequencies. So in this patient, there is a high frequency hearing loss. And also, what is the hearing loss? Is it conductive or sensorineural? Yes, there is no AB gap, so it is a sensorineural hearing loss. High frequency sensorineural hearing loss means which turn of the cochlea is affected? Yes, the basal turn is for high frequency. And can you tell me in which condition will you see this audiogram? Yes, so whenever we see a high frequency hearing loss, that is known as a downsloping. So many a times audiogram is given. When the audiogram is given, you can see and you can make out, yes, it is a high frequency hearing loss. Many times it is not given that it is, the audiogram is not given, it is just mentioned downsloping audiogram. So downsloping audiogram means what? High frequency. How can you remember? When the slope in front of you is going down, where are you standing? You are standing up. So whenever you are seeing a downsloping means you are up, means it is high frequency hearing loss. You are high, it means it is a high frequency hearing loss. And this you will see in 3 conditions. Age-related hearing loss, that is presbycusis. You will see it in ototoxicity. And the third is noise-induced hearing loss. In noise-induced hearing loss, this pattern is seen late. The earliest finding that you see in noise-induced hearing loss is a dip at 4,000 hertz. Is that clear? And that type of dip of sensorineural hearing loss at 4,000 hertz is what is known as acoustic dip. Acoustic dip. Clear? Okay, so now, yes, tell me this. Which ear? Looks like both the ear. Tell me what is this? Yes, round. Yes, this is the right ear. And this is wrong. And yes, this is the left ear. Okay, now let us see whether it is normal or not. Right ear is normal. Left ear, what about left ear? Yes, in the left ear we are seeing that there is hearing loss, but only in the low frequencies. And also, what's the hearing loss? Yes, no AB gap. So it is a left ear low frequency sensorineural hearing loss. Low frequency is involved. It means where is the defect? Yes, it means the defect is in the apex of the cochlea. And can you tell me that this is specifically seen in which condition? Yes, very good, that is seen in mean ears. And is mean ears a unilateral condition? Yes, we can see one ear is normal, only one is defective. Yes, it is a unilateral condition. So yes, this was a question. This is the pattern that the questions on audiogram are asked nowadays. Earlier it was just the audiogram given and it is conductive or sensorineural hearing loss, right? So now let us see this question. A woman had tinnitus and hearing loss. Okay, tinnitus, hearing loss and episodic vertigo, which lasted for 2 to 3 hours. Each pure-tone audiogram is shown. What is the likely diagnosis? So the history, is it telling you something? There is hearing loss also, vertigo also, which means the complete inner ear is involved, cochlear as well as the vestibular part. Yes, it can be mean ears. Yes, the vertigo here lasts from 20 minutes to 24 hours. Yes, it can be mean ears, and this is adding on to the diagnosis. Yes, it is low frequency sensorineural hearing loss. So yes, the diagnosis is mean ears. Okay, now we had this question again recently. A patient complains of decreased hearing in the left ear. Okay, audiogram is given below. What would have been the tuning fork test in this patient? So in this patient, if you do not know to read the audiogram, you will not have the answer. So yes, what is this audiogram showing? We already saw that this is showing left ear sensorineural hearing loss and the right ear is normal. So tell me what will be the tuning fork test, and however I told you, whenever we have to write the tuning fork test, we will always approach in this manner: right, left, Rinne's and Weber's, right? So now if it is a right ear normal, Rinne's will be positive, and left ear sensorineural hearing loss, Rinne's is positive in which two conditions? Normal and sensorineural hearing loss. So again it will be positive. And what about Weber's? The mnemonic of Weber's, quickly tell me. It is SOX. SOX. What is SOX? In sensorineural hearing loss, Weber's is towards the opposite side as the disease. That is, it is towards the better ear, opposite to the disease. Whereas in conductive hearing loss, Weber's is towards the same side as the disease, that is towards the same side as the disease, that is the worst ear. So what will be Weber's? In this patient, there is left sensorineural hearing loss. So in sensorineural hearing loss, it is towards the opposite side, that is the better ear. That was simple, right? Yes, so but for that you first have to know what this audiogram is showing. Only then you can come to this diagnosis. So now, yes, now this audiogram you tell me completely. This I will not tell you. Yes, which ear? Which ear? Yes, this is, yes, opening towards the left ear. This is also left ear. This is bone conduction and this is air conduction. Next step, what will be the next step? Normal or not? Yes, up to 25 decibel is normal. So in this patient, we are seeing that bone conduction is normal, means yes, sensorineural hearing loss is sensorineural pathway is good, and yes, there is AB gap, which means that there is a conductive hearing loss. So this patient has a conductive hearing loss in the left ear, and also you are seeing something very, very special here. Yes, we are seeing that there is a dip only in the bone conduction. Bone conduction is normal, but there is a dip in the bone conduction, specifically at 2000 Hz. So this is specially seen in otosclerosis, and this is what is known as Carhart's notch. This is known as Carhart's notch. So whenever you are seeing a conductive hearing loss plus Carhart's notch, what you have to think of? You have to think of otosclerosis. By chance Carhart's notch is not there and the history is suggestive of otosclerosis, yes, again it can be otosclerosis. Not necessary that all otosclerosis will show the Carhart's notch, but yes, all otosclerosis will show conductive hearing loss, and yes, it is usually bilateral, right? Okay, so now, yes, we had this question that was asked again this year. A 40-year-old female, yes, presents with progressive bilateral conductive hearing loss. PTA is shown below, which sign? So yes, I have asked you, do not jump on seeing the audiogram. First, is the history telling you something? 40-year female, any adult female or any adult male also can be, more common in female. With bilateral conductive hearing loss, what should come to your mind? Otosclerosis. Again, let me ask you what I have told you earlier. Any child with bilateral conductive hearing loss, what will come to your mind? Serous otitis media. Any elderly with unilateral sensorineural hearing loss, what will come to your mind? Acoustic neuroma. Any adult with bilateral conductive hearing loss? Otosclerosis. So this itself tells us that this is otosclerosis, and yes, the audiogram is also telling us that this is otosclerosis. And what is asked here? See the question, what sign will be seen in this condition? Which means you have first diagnosed that this is otosclerosis. What sign is seen in otosclerosis? Yes, Schwartz sign. What is Schwartz sign? Schwartz sign is seen in active otosclerosis. Schwartz sign is seen in active otosclerosis, and that is the flamingo pink appearance. That can be because of the increased vascularity on the medial wall that can be seen usually in the posterior superior part where we have the oval window area, or it can be seen in the round window area or the promontory also. Okay, so tell me, what is this test? Yes, you cannot miss this. Here we are giving sound to the patient, to this child, and electrodes are attached all over the head of the child. Yes, so this is how BERA is done. Subjective or objective? You give the sound, electrodes are attached, and the result you get in the form of a graph. Yes, this is an objective test, and the graph of BERA looks like this. It has a total of 5 waves. A repeated question of your exam is that which is the largest and most consistent wave? Yes, largest, most consistent wave is wave 5. Wave 5 stands for what? Again is a question, it is from the lateral lemniscus. So the BERA measures from the sound stimulus to up till 10 milliseconds. And that consists of 5 waves, and all these waves we need to know. Yes, BERA tells us whether it is a cochlear or retrocochlear hearing loss. BERA tells us where exactly in the retrocochlear pathway. Wave 1 starts from the nerve in the inner ear, that's the distal part of the cochlear nerve. 2 is the proximal part of the cochlear nerve. 3 is cochlear nuclei. 4 is the superior complex. And 5 we know is lateral lemniscus. So it will exactly tell us where exactly in the retrocochlear pathway there is defect or not, or where exactly is the defect. So this is the best test to differentiate cochlear and retrocochlear hearing loss. And also, if there is a retrocochlear pathology, this is the best audiometric test to find out whether it is acoustic neuroma or not, right? So for acoustic neuroma, the best investigation is, don't tell me BERA, best is MRI, it is an intracranial tumor, but best audiometric test is BERA, right? Okay, so now can you tell me, what is 1 and what is 2? Is 2 BERA? Can you see any electrodes on the head of the patient? No. So this 2 is autoacoustic emission. And what is 1? Yes, 1 is BERA. What is autoacoustic emission? Yes, in this test we give a sound. The sound travels from the external ear to the middle ear to the inner ear, in which we have the outer hair cells. And the outer hair cells, in response to the sound, the movement of the outer hair cells, which are lots in number, so their movement produces a sound which travels back from the inner ear to the middle ear and then to the external auditory canal, and it is picked up by this probe. So when the probe picks up the sound, it immediately gives the waves which you see on the in the device, or it can come as a tick sign, and this response we call it as a pass response. So the report that you get is a pass response, or if it is absent, the report that you get is refer. So that is again another question of your exam, that when you get a refer, it is refer for what? Yes, it is refer for 2 things. The first thing is you have to be sure that the sound has reached the inner ear, which means the sound, the external ear and the middle ear is normal. Only then the sound will reach the inner ear and the sound from the inner ear will come back. So the first thing is you test the middle ear whether it is normal or not. And which is the test to test the middle ear? Yes, that is tympanometry. And the second is you refer for BERA. BERA to reconfirm whether it is a cochlear or retrocochlear hearing loss. Yes, and also to know that if there is a nerve defect also, then in this patient who has a defect of the organ of Corti, we cannot go for cochlear implantation. Is that clear? So refer for 2 things, tympanometry and BERA. Yes. What is this? Yes, this is a repeated question. This we are turning the patient's head towards the right. So we are testing the right vestibular system and then down. So we are testing the right posterior semicircular canal. Yes, this is a test for BPPV. Can you tell me the name? Yes, this is the Dix-Hallpike maneuver. This is the Dix-Hallpike maneuver. And if it is positive, then we go for repositioning maneuver. And that is what is the Epley's maneuver. This is how the place maneuver looks like. And if in your exam this is given, the second picture, this one, what is this? This is also a place maneuver. In the first picture it is given in the form of a round, and the second it is given in a straight line. So both these are a place maneuver. And yes, year is never complete without this question. So the given procedure was done in a deaf child. Identify the marked openings. Suggestive of deaf child means what is being done, cochlear implant. Yes, and there was another picture, we will come to this. Yes, another picture in your exam. This was given and was asked what procedure is being done in this deaf child. So whenever the deaf is mentioned, we know what is being done, cochlear implant. Yes, so what is done in cochlear implant is that to place the electrodes, we drill the mastoid, we place the internal component there, and the electrodes we pass from the mastoid into the middle ear by making an opening on the posterior wall of the middle ear. Yes, so let us see this first, understand this first, and then we will come to that picture. Okay, so here what we do is we have studied this, that this is the mastoid. So from the mastoid we have to pass the electrodes into the middle ear. How do we pass the electrodes? By making an opening in this area. This is what is known as the facial recess area, and that is bounded medially by the descending part of the facial nerve, laterally the chorda tympani, and superiorly the fossa incudis. What is present on the fossa incudis? The short process of incus. And what is this? Yes, this is the otitis, right? So when we have to make an opening in this area, how do we know that this is the exact area where we have to make the opening? Yes, we drill the mastoid, and through the mastoid we see through the otitis, right? When we see through the otitis, we see the short process of incus. We are able to see the short process of incus. So we know that just below that will be the facial recess where we have to make the opening. Now let us see this in this picture. So here we will first drill the mastoid, and now through the otitis, that is in the upper part, we will see the incus, the short process of incus. So see very, very carefully. Are you able to see this? Yes, this is the short process of incus. And what is this here? Yes, this is the malleus, the head of the malleus. So again, this appearance is what is known as an ice cream cone appearance. This is the head of the malleus, and this is the short process of incus that you see when you are seeing through the otitis. Ice cream cone we have heard somewhere else also. Yes, that. Yes, very good. In the CP angle tumor acoustic neuroma. This is also the ice cream cone appearance. So the moment you see the short process of incus, we know that we have to make an opening below that. And what is below that? This area that is bounded medially by the facial nerve, laterally by the chorda tympani, and superiorly by the fossa incudis. Is that clear? So now when we see it, when the patient is lying down, that is how we operate. So how will it appear? Yes, this we will drill the mastoid, and then we will make the opening here. How will we make the opening here? We will first see through the otitis the short process of incus, and below that will be this opening made. Is that very clear? Okay, so now again, yes, I will just show you this also. This is the facial nerve, this is the chorda tympani. Facial nerve, chorda tympani, superior is the fossa incudis. This is the area where we make an opening while doing cochlear implantation also, while doing intact canal wall mastoid surgeries also. So now again, this picture that was given in our exams, yes, I am showing you a different picture, but this is more identifiable. So this is the first picture. See the first picture. In the first picture, we have drilled the mastoid, and what we are seeing is the otitis, through which you can see the ice cream cone, the short process of incus, and the malleus head. So where the short process of incus is coming on the posterior wall, that is the fossa incudis, and below that we have to make the opening. So we have made the opening in the facial recess area. This is the facial recess area where we have made the opening, and through the facial recess, we will be able to see the round window. So the electrodes we pass from the facial recess through the round window into the inner ear. And above that, are you seeing the stapes? So above that will be the oval window. Is that very clear? See again, I have rubbed everything for you. Yes, I will now mark 1, 2, 3, 4. You will tell me. 1, what is 1? Otitis. Okay, 2, short process of incus. 3, this will be the fossa incudis area. Okay, tell me 4, vertical part of facial nerve. 5, chorda tympani, 6, this is the round window, and 7. Above the round window, we will see the oval window where we are seeing the stapes. So now let us come to that question and see. Yes, the given procedure was being done in the deaf child. What is the marked structure? The marked structure is, yes, we know cochlear implantation is being done, and the 1 is this big opening and the 2 is the small opening. So yes, the 1 is the facial recess area and the 2 is the round window. And don't think that how will you recognize among all the things in the body what this is. Yes, the choices were round window, oval window, otitis and the facial recess. So then you know it is something of the ear, and what is being done is cochlear implantation. Where is the otitis? Can you mark that for me? Yes, above this. This is the fossa incudis. Above that, this is the otitis where you are seeing the ice cream cone appearance, right? If you can make out. And yes, again this is cochlear implantation being done, and in this picture, yes, again this is through the otitis you can make the ice cream cone, the short pros of incus, the fossa incudis, and this is the opening that we have made in the facial recess through which we can see the round window. Is that clear? Yes, these pictures are actually bad because this is how we actually see in the surgeries of the ear. Yes, the next question. The given images is of a patient whom mastectomy is done. Identify the lateral semicircular canal. So how do we identify? So always remember that whenever you are seeing, yes, the mastoid, you have opened the mastoid, where do you find the semicircular canals? The semicircular canals are always present in the superior part of the mastoid. Let me first show you this picture. Yes, you have seen this picture already. So here, when you drill the mastoid, where will you find the semicircular canals? You will find it, once you have completely drilled the mastoid, you will find the semicircular canals in the upper part of the mastoid. Yes, if you drill more, you will find it in the upper part of the mastoid. So now let us come back to this. Yes, so you will see the semicircular canals in the upper part of the mastoid. So wherever you are seeing the semicircular canals, it means that that is the upper part of the mastoid, which means that whenever you are seeing this picture, you will first try to identify which is the upper part, lower part, anterior and posterior part, right? So it means this is the upper part, so this is the superior part, this is the inferior part. So this is the mastoid that you have opened, so this inferior part will be the mastoid tip part, which is the anterior and which is the posterior. We can see the external auditory canal here, so that is the anterior part, and we can see the sigmoid sinus here, so that is the posterior part. Is that clear? So now once you have oriented yourself, now it will be easy for you to identify the semicircular canals. So the semicircular canal which is superiormost, that is this one, this will be the superior semicircular canal. We know this is posterior, so the posteriormost will be the posterior semicircular canal, and the semicircular canal which is towards the middle ear, this is the external auditory canal. So we will have the middle ear here. So towards the middle ear, that will be the lateral semicircular canal. Is that clear? It is that simple. Now have a look at this picture. This is a more closer and a more magnified view. So what we are seeing is the semicircular canals. So if we are seeing the semicircular canals, we know that this is the superior part, right? We see it in the superior part of the mastoid, which means this is the inferior part, which is the anterior and which is the posterior part. Yes, so let us first see. We have made out that this is the superior semicircular canal. Now what else are we seeing here? See carefully. See carefully. We are seeing this. What is this? Yes, this is the nerve, the facial nerve which is coming down. Facial nerve which is coming down. This is the chorda tympani. And what is this structure? This is the short process of incus, right? Short process of incus, and this is the head of the malleus. This is the ice cream cone, which means that in this patient, the fossa incudis area has also been drilled. So instead of making just the opening here below the fossa incudis in the facial recess area, they have also, to show you, yes, they have also removed the fossa incudis area, so you can see through the mastoid the middle ear cavity so beautifully, which means, which is the semicircular canal towards the middle ear? This one. Yes, just below that is going the facial nerve. Yes, we know that the facial nerve goes just below the lateral semicircular canal. So this is the lateral semicircular canal and this is the posterior semicircular canal. Also we can see this bluish, so we know that this has to be the sigmoid sinus. So what is this arrow marked structure here? The black arrow marked structure? Yes, this is the short process of incus, short process of incus. Is that clear? This is the picture that has been asked in your exam and you repeatedly keep asking me what this is. So have you understood that now? So that completes the ear section images. So you can have some coffee, go wash your face. Yes, and then we'll start the nose section. So starting with the nose section, yes, the first question, the mark structure opens in which area? Yes, that was a question this year. A spotter we have here. So we have the inferior turbinate, the middle turbinate, the superior turbinate, and what's the structure that has been marked? Yes, this. So this is a sphenoid sinus opening above the superior turbinate in the sphenoethmoidal recess. Yes, so sphenoethmoidal recess. Yes, again, identify the arrow mark structures. So now this is some endoscopic picture which you repeatedly ask me. So what is this? So whenever we see any endoscopic picture of the nose, the first thing is to identify which one is the lateral wall, which is the septum, and where you are seeing the floor, right? So how do we identify the lateral wall? We know that in the lateral wall we have the multiple turbinates, and the turbinates, they are attached to the lateral wall, which means that they will appear as separate structure from the lateral wall. Whereas even if there is a deviation of the septum, it will not appear as a separate structure from the septum. It will appear a smooth deviation of the septum itself. So here what we are seeing is that we can see some structures which are appearing as separate from the wall, which means that these structures have to be the turbinates, which means if they are the turbinates, then this is the lateral wall and this is the septum. Yes, can we also make out the floor? Yes, this is the floor, and yes, we know that the anterior most and the inferior most, starting most anteriorly and most inferiorly, this is the inferior turbinate. So what structure has been marked as the inferior turbinate? The middle turbinate starts a little more posteriorly and it is superior to the inferior turbinate. So this here what you are seeing is the middle turbinate. Is that clear? So let me rub this. Yes, can you make out now? Yes, what is 1? Inferior turbinate, 2, middle turbinate, 3, septum, 4. This is the floor of the nose. A 45-year-old male presents with nasal obstruction and undergoes CT scan of paranasal sinuses. Identify the blocked sinus. So we will come to this question. Before that, let us see some important things that we should know before we go to the CT scan. So yes, in the lateral wall, we have the turbinates, and lateral to the turbinates, we have the meatuses. So lateral to the inferior turbinate is the inferior meatus, middle turbinate is the middle meatus, and superior turbinate is the superior meatus. In the inferior meatus, we have the opening of the nasolacrimal duct. In the middle meatus, we have the opening of all the anterior group of sinuses. Can you tell me what the anterior group? This is the anterior group, frontal, anterior ethmoid and maxillary. In the superior meatus, we have the opening of posterior ethmoids. And sphenoid, we already saw it is in the sphenoethmoidal recess. Now, let us see these meatuses. So, here we have the septum in the center. This is the inferior turbinate. So, just lateral to the inferior turbinate, this will be the inferior meatus. This is the middle turbinate. So, in the middle meatus, we have many important structures. We have the opening of all the anterior group of sinuses, making the middle meatus the most congested meatus. Largest meatus is inferior, but most congested is middle. Okay, so what are these structures? Now, see here, inferiorly, can you see this? Yes, this is a bone that is a part of the ethmoid bone. This is known as uncinate process. Superiorly, here we have a bulge that is produced by the biggest, or we can call it the most prominent anterior ethmoidal cell. This is what is known as B for biggest, B for bulla ethmoidalis. And this gap that we can see in between the uncinate inferiorly and the bulla superiorly, this gap is a semilunar opening so hiatus semilunaris, right? And through the hiatus semilunaris, you enter into this area. You enter into this area that is, yes, where I made the star, and that is in between the uncinate process and the lateral wall. This is what is known as the infundibulum. This is known as infundibulum. And we can see very clearly that the maxillary sinus is opening directly into the infundibulum. Is that clear? Yes, maxillary sinus opens in which meatus? Middle meatus. Exactly which part of middle meatus? Into the infundibulum. And superiorly here, we have the frontal sinus opening through the frontal recess. That's the narrow duct through which the frontal sinus opens in the middle meatus. That is known as frontal recess. Now let us see the CT scan. Okay, so here, tell me, what is this? Very good, the septum, inferior turbinate, inferior meatus. Yes, tell me. Yes, the middle turbinate. Yes, so now in the middle meatus, tell me what is this? Uncinate process. Yes, the bulla ethmoidalis. And this gap is hiatus seminal through which you enter into the infundibulum, into which opens the maxillary sinus directly, right? This is the infundibulum. And here what is this? Yes, these are the two orbits. And see carefully, in between the orbit and the ethmoid, is a thin papery bone. This thin papery bone is what is known as lamina papyracea, like a paper. So, papyracea, lamina papyracea. Yes. So, ethmoid is the most common cause of infections to the orbit, right? Ethmoid sinusitis. Okay. So, now also see some more things here. Now this here is the cribriform plate, right? Cribriform plate has a medial lamina. I will just enlarge it. Yes, the cribriform plate has a medial lamella and it has a lateral lamella. So this complete like a vessel, this is the cribriform plate. And what is this? What is this bone here? So yes, this is the extension of the orbital plate of frontal bone forming the roof of the ethmoid sinuses. This is what is known as fovea ethmoidalis. So, fovea ethmoidalis is a part of frontal bone, extension of orbital plate of frontal bone which forms the roof of the ethmoid air cells. And the most common site of fracture leading to CSF rhinorrhea is the lateral lamella of the cribriform plate, because this is a very thin bone articulating with a relatively thick bone, the fovea ethmoidalis. So, the most common site of CSF rhinorrhea is lateral lamella of cribriform plate. Is that clear? Okay, so now also we need to know that the anterior ethmoid cells have been named. Yes, the anterior ethmoids are usually supposed to be present only in relation to the medial wall of the orbit. But if the anterior ethmoids are extensively pneumatized, then they go and they lie in relation to inferior wall of the orbit also, in relation to superior wall of the orbit also, right? As you are seeing in this picture that the ethmoid air cells are present in relation to the inferior wall of the orbit also. This is what is known as the Haller cell. Whereas it is also in relation to the superior wall of the orbit. This is what is known as supraorbital cells. Supraorbital cells. Right? So, okay. So, what are the named anterior ethmoidal cells that you know of? Yes, we know of the most prominent, remember it as the biggest, B for biggest, B for bulla ethmoidalis. In relation to the floor of orbit, is sometimes asked as in relation to the roof of maxillary sinus. Is it the same? Yes, it is the same. This is what is the Haller cell. And yes, can you make out that the Haller cell is important? Why? Because it is blocking the infundibulum into which the maxillary sinus opens. So, it can cause recurrent maxillary sinusitis. Now, also the extensively pneumatized anterior ethmoids, they can extend anterior to the anterior attachment of the middle turbinate. So, when they extend so anteriorly, they are known as agarnesi. So, this is the site of agarnesi. So, how do we remember that? Yes, anterior most, A for anterior most, A for agarnesi. So, how do we identify the Haller cell? Do you know? Can you identify? Yes. How do you identify the agarnesi? Okay, so in this picture I have just marked where the agarnesi will be. Now let us see the CT scan. This is the sagittal cut that you are seeing, the second picture. Now in this, what you are seeing is Yes, you are seeing the frontal sinuses here. Here we have the anterior ethmoids, we have the posterior ethmoids, we have the sphenoid. So now, which do you think is the anterior-most anterior ethmoidal cell? The one that is here, the anterior-most. So that is the agar nasi. How do we identify the agar nasi in the coronal cut? Yes, so in the coronal cut, since the agar nasi is the anterior most, it will be seen in that section which is very anterior. So if we are taking a cut section from here, yes, which means that will be the very anterior cut section. So in that very anterior cut section, the frontal sinuses will be seen. We will see the agar nasi and the maxillary sinuses, they will be just appearing because it is very anterior. In more posterior cut, the maxillary sinus will appear huge. So which means that, how do you know that this is the frontal sinuses? Yes, by seeing that the maxillary sinuses are very small here. So if the maxillary sinuses are just appearing, it means there is a very anterior cut. So these sinus that we are seeing is the frontal sinus, and this air cell that we are seeing is the anterior-most anterior ethmoidal cell, that is the agar nasi. Have you understood that? Okay. So now, how the anterior ethmoidal cells can be extensively pneumatized. Similarly, the posterior ethmoidal cells can also be extensively pneumatized. If they go, where will they go? Yes, so the posterior ethmoids are in close relation to posterior to that is the sphenoid sinus, which means just see here, here we have the frontal sinuses. Yes, we have the anterior ethmoids, we have the posterior ethmoids. Now the posterior ethmoid, just posterior to that is what? It is the sphenoid sinus. So the posterior ethmoids, when they become extensively pneumatized, they go, as you see here, they go around the sphenoid sinus, and the posterior ethmoidal cell which reaches around the sphenoid sinus has been named as Onodi cell. This is a very, very important question of your exam, Onodi cell. Onodi cell is a part of posterior ethmoid, but it is in relation to, when word changes in the question, the answer changes, it is in relation to the sphenoid sinus. How is that important? So now let us see this coronal cut section in which we are seeing the sphenoid sinus. Now in the sphenoid sinus that we are seeing, yes, this is the septa separating the two sphenoid sinus. Let us see this part. Now in this sphenoid sinus we are seeing that superior and a little lateral, this is the optic canal through which goes the optic nerve. And here laterally we have the cavernous sinuses. Lateral to the sphenoid sinus we have cavernous sinus through which passes the internal carotid artery. Is that clear? So now let me rub here, which means that the internal carotid artery and superior the optic nerve are in close relation to the sphenoid sinus. But they are usually not injured in sphenoid sinus surgery because the bones of the sphenoid sinus are very hard. So unless and until it is dehiscent, injury does not occur. Now let us have a look at the other side. On the other side, what we are seeing is that there is a horizontal septa. So whenever there is a horizontal septa inside the sphenoid sinus, so it means that the cell that is above it, this is the Onodi cell. So now we can see that the Onodi cell has come above the sphenoid sinus, and now the optic nerve as well as the internal carotid has come in close relation to the Onodi cell. So while operating on the posterior ethmoid on the Onodi cell, because the Onodi cell, the posterior ethmoid's air cells have very friable walls, now there will be high chances of injury to both these structures. So again, that is a question of our exam, and in fact the injury to the internal carotid artery is the most dreaded complication of FES. So now can we identify all these cells? Okay, so now let us see what more we need to know on the CT. So yes, tell me, this is, yes, the septum. Is this patient having a DNS? Yes. Now this is the inferior turbinate, and yes, we are seeing the middle turbinate. Now just see the middle turbinate. Normally the middle turbinate is supposed to be like this. There is no air supposed to be present inside the middle turbinate, but if there is air in the middle turbinate, in other words, pneumatization of middle turbinate is what is known as concabullosa. Concabullosa. And concabullosa is seen most commonly in the middle turbinate. Can we see that? Yes, here the concabullosa is in the middle turbinate. Now also what we are seeing on this CT scan is this inferior turbinate is also appearing very huge. Yes, but that is not because of air within it. That is because of an external hypertrophy of the skin, the mucosa, the fibrous tissue. Yes, so when there is an external hypertrophy of the mucosa and the fibrous tissue, that is what is known as a hypertrophic turbinate. And the hypertrophy of the turbinate is seen most commonly in which turbinate? In the inferior turbinate. Is that clear? So now, how will a concha bullosa look like? A pneumatized turbinate appears very huge, polypoidal. It is confused with a polyp. And how do you differentiate it? That is by a probe test. You can pass a probe all around the polyp, and when you probe the polyp with the probe, then it does not bleed and does not pain. Whereas a turbinate will bleed, it will pain. So it is confused with polyp. So now let us come to this question. Yes, we have to identify the blocked sinus. Now we can see all the sinuses here. Yes, septum, inferior turbinate. Yes, this is ethmoid air cells. The orbit, tell me this. You have to tell me, yes, this is the lamina papyracea. Here we can see that the ethmoids are extending so much superiorly also. This is the supraorbital ethmoidal air cells. Yes, don't confuse this is frontal sinus. This cannot be frontal sinus because the maxillary sinuses that you are seeing are so big, which means that this is a posterior cut. And frontal sinus is seen only in the anteriormost cut. Is that clear? So which sinus is blocked here? Yes, we can see the maxillary sinus. Name the anterior most ethmoidal cell marked in the figure. Do you even need a figure to mark that? Because it is already written anterior most. Anterior most is A for anterior most, A for agar nasi. Yes, so you already know the answer, but yes, what is marked is this. Yes, that is the site for agar nasi. Identify the marked structure in the given scan. So this was a scan, and what's the marked structure? This we are seeing is the septum, the inferior turbinate, this is the middle turbinate, this is the bulla ethmoidalis, and this marked structure is something above it. Let us see the choices. So always whenever it is a spot diagnosis given and you cannot come to a diagnosis, see the choices. Yes, the examiners definitely do not want to test what you do not know. They want to test what you know. Yes, so let us see. The first choice is pneumatized superior turbinate. Agar nasi. Agar nasi, can this be agar nasi? This air cell, can it be agar nasi? Yes, agar nasi is seen in the anteriormost cut where we will see the frontal sinuses here, and the maxillary sinus will be very small. Here the maxillary sinus is so big, and yes, we are not seeing the frontal sinus also, so this cannot be agar nasi. So no, this is not agar nasi. Concha bullosa, can it be concha bullosa? Concha bullosa is pneumatization of the middle turbinate. No, this is not the middle turbinate. We can delineate the middle turbinate very clearly here. Onodi cell. Onodi cell will be seen in relation to the sphenoid sinus. Are we even seeing the sphenoid sinus here? No. So no, this cannot be the Onodi cell also. So pneumatized superior turbinate, let us have a look again at this picture. Pneumatized superior turbinate. Yes, this is the middle turbinate. This is the superior turbinate. Yes, it is pneumatized superior turbinate. So this is how by ruling out you can come to the answer. Now X-rays again are asked commonly in our exams. What is this view? Yes, this is the most commonly asked view, and this is how the Waters view look like. So how do you know it is the Waters view? Waters view is the occipital mental view, and this is a nose chin position, means the nose and chin are touching the frame. So you will see the lower border of the mandible like this, right? And it will be a front view, and the best seen here will be the maxillary sinus. Let us see what are the other sinuses that are seen here. Yes, we will see the frontal sinus, the anterior ethmoid, the maxillary sinus. Okay, so sinus seen best is maxillary here. Whereas if you do Waters view with open mouth as here, then you are also able to see the sphenoid sinuses. So again, let us see what sinuses. We have the frontal, the anterior ethmoid, we have the maxillary, that is the best seen here, and here we have the sphenoid sinuses also. And this is what is known as Pear's view. If Pear's view is not in the choice, you can mark it as Waters view with open mouth. The next is the lateral view. Lateral view, you see all the sinuses as in the lateral view of the CT. We see the frontal sinus, we have the anterior ethmoid, we have the posterior ethmoid, and we have the sphenoid, above which we can see the sella turcica, which is the seat for pituitary. Yes. So can you make out all this? So was asked in your exam that all sinuses are seen in which view? And in lateral view, which is the superior most. Yes, so superior most, is it the sphenoid or is it the frontal? Obviously, it is the frontal. The radiograph shown below is done for better assessment of frontal sinus. So for frontal sinus, what is the common name of this view? Yes, so they have given the answer also. This is for frontal sinus. So for frontal sinus, the view that we get done is the one where the frontal bone and the nose, they directly face the frame. So the X-ray film. Yes, so the frontal sinuses appear very prominent there. This is known as the nose and the forehead position, and this is the occipito-frontal position. Whereas Waters view is what? Waters view, how do you put water? It is like this. So it is occipito-mental. This is occipito-frontal. Yes, and this is the best for frontal sinus. This is known as Cadwell's view, right? This is Cadwell's view. So how do you differentiate when the X-ray is given? Which one is Waters and which one is Cadwell's? I am sure you are able to make out. Yes, in Waters view, you will see the mandible like this, like the inverted U, whereas in Cadwell view, because it is the nose like this, it is the nose and the forehead is touching the film, it will appear, this will appear straight, and here you can see the frontal sinuses very clearly, here you can see the maxillary sinuses very clearly. So again, this was a question this year. A 7-year-old male presents with progressive bulging of one eye with diminution of vision since one day. He has a history of URTI on examination. It is seen that he also has nasal congestion with active discharge. CT scan of PNS is seen. What is the diagnosis? So with the question, what comes to your mind? It is a child with, yes, features of sinusitis, acute sinusitis leading to some complication of the eye. So yes, acute complications of sinusitis are seen more common in children. And out of all the complications, most common complication is orbital complication. And orbital complication follows most commonly with sinusitis, ethmoid sinusitis. So this is some complication that has followed ethmoid sinusitis. Which one? Okay, so now let us see the X-ray, the CT. So before we come to this question, let us see what the orbital complications are. So the orbital complications of the sinusitis, they are divided by Chandler into 5 groups. Now group 1, yes, first let me orient you. This is the transverse cut section. This is the nose, yes, and this is the eyes that we are seeing. This is the nasal cavity. In the center is the septum, and here these are the ethmoids, the anterior and the posterior ethmoids. In between the ethmoid and the orbit, this is the thin papery bone. Can you tell me the name? Yes, that's the lamina papyracea. This here is the cone of the orbit. This is the eyelids that we are seeing. Okay. So now with that much, let us see what is happening here. The first is what is known as preseptal cellulitis. Here the cellulitis is just in front of, anterior to the orbital septum. Anterior to the orbital septum. So here this will present just with eyelid edema and erythema. Let us see how this appears on the CT scan. So here can you see that there is edema and erythema only of the eyelid. The moment you open the eye, everything inside is appearing good. So this is just inflammation anterior to the septum, preseptal cellulitis. How will this appear on the CT scan? Can you make out this CT scan? What you are seeing here? Yes, this is the nose. This is the eye. Here is the septum. Here will be the ethmoid sinuses, and this is the thin papery bone, lamina papyracea. This is the cone of the orbit. So we can see here very clearly that where is the inflammation? Only anterior to the septum. This is what is preseptal cellulitis, right? So this is preseptal cellulitis. Okay, the next is orbital cellulitis. Orbital cellulitis is cellulitis inside the cone. Now always remember that whenever there is inflammation inside the cone, edema inside the cone, any mass or abscess inside the cone, that will push the orbit What is that known as? Proptosis. And will that be an axial or a non-axial proptosis? Yes, axial proptosis means that the pushing is only in this plane, horizontal, whereas non-axial means that there is pushing along with outside in the horizontal plane. There is also a displacement of the vertical plane, in the vertical plane, which means that, for example, if there is any mass in the frontal or the ethmoid sinuses, it will push the orbit not only outside but also inferiorly, laterally. Similarly, lacrimal gland swellings will push it also medially. Maxillary sinus will also push it upward. So, if the proptosis is not only in the horizontal plane but also vertical, that is non-axial, right? So, cellulitis will lead to axial proptosis, and here there will be also, when you open the eye, there will be chemosis, redness, there will be restriction of ocular movement because of so much edema inside. There can also be diminution of vision because of nerve involvement of thalmoplegias. Yes, so if you see this on CT, how will this appear? Yes, can you see there is chemosis, there is proptosis? Yes, and see the CT scan. Can you see the CT scan? Yes, we are seeing that there is a lot of inflammation, edema inside the orbit. This is the nose, the lamina papyracea, everything is appearing good. Inside the orbital cone, there is edema pushing the orbit outside. Right? Now, yes, coming to the next stage is subperiosteal abscess. What we are seeing here is that this here is the lamina papyracea. So, the periosteum of the lamina papyracea will be raised, and below that will be abscess, pus collected. This is subperiosteal abscess. Now, tell me that if there is subperiosteal abscess, yes, definitely there will be chemosis, proptosis, but will this proptosis be only axial, or it will also push the eye laterally also? Yes, it will be non-axial, and there will be chemosis, proptosis. All these things will be seen after orbital cellulitis and all the stages: chemosis, proptosis, restricted ocular movement. All this will be seen in all rest of the stages. So now let us see. Yes, can you make out this? In this patient, what you are seeing? Yes, you are seeing chemosis. You are seeing also proptosis, and we can see that it is also pushed laterally as compared to this, right? And just by seeing the eye anyways, we cannot make out what it is. We can make it out by CT scan. So that is why you have been asked on the CT scan. So yes, here inside the nostril we can see the anterior ethmoid, the posterior ethmoid, all of them are infected, and we can see that there is a subperiosteal abscess. Can you make out? See again. Can you make out? Yes, there is a subperiosteal abscess pushing the orbital cone on one side. So now the next stage, yes, the next stage is the orbital abscess, where there is an abscess inside the orbital cone. Yes, all these symptoms will now gradually increase, and orbital abscess, usually there will also be total ophthalmoplegia. So yes, we are seeing here, can you see the grade, all the grade of proptosis, chemosis, everything will increase as the stage increases. So here, can you make out? Yes, we can make out here that there is this abscess cavity inside the cone of the orbit. And the last is cavernous sinus thrombosis, when because of the common venous drainage of the eye, the superior and inferior ophthalmic veins, the infection will go into the cavernous sinus. How do we find out whether it has gone to the cavernous sinus? Yes, the cavernous sinus of both the sides intercommunicate. So when there is a cavernous sinus thrombosis, this condition becomes bilateral, and has been a repeated question of your exam that when the other eye is also involved, what is the earliest nerve to be involved in the other eye? Yes, so in cavernous sinus thrombosis, since the sixth nerve passes through the cavernous sinus, the earliest nerve to be involved will be the sixth nerve. Other nerves that can be involved is the third and the fourth nerve, all the eye nerves, right? So now, yes, can you make this one out? Yes. Here we are seeing that there is bilateral involvement. Whenever there is bilateral involvement, it is cavernous sinus thrombosis. So now let us come back to this question. So yes, what are we seeing on the CT? We are seeing the lamina papyracea, the ethmoids are involved, and yes, just adjacent to the lamina papyracea, there is an abscess collection, subperiosteal abscess. Yes. So what is the answer? Sinusitis with subperiosteal abscess. So what are you seeing here? Yes, we can see that the eye is pushed laterally, also downwards. Yes, and also there is proptosis. What is this? Yes, this is non-axial proptosis, and when the proptosis is only laterally, it is because of proptosis, and laterally it is ethmoid. If it is down also, it means it is coming from above, from the frontal sinuses. Yes, that is what we are seeing in the CT. And also in the MRI, we are seeing there's collection in the frontal sinuses. This is the typical appearance of mucocele. Yes, mucocele is seen most commonly in the frontal sinus because the frontal sinus drains through a very narrow duct into the middle meatus. This is known as frontal recess. Obstruction of this duct is seen very commonly following chronic sinusitis. This is also seen very commonly following injury to the duct. This injury can occur following surgery. With surgery, FES, or it can occur following non-iatrogenic trauma. Any trauma in this area can injure it, block it, leading to collection of secretions in the frontal sinus, and that is what we call as mucocele. So yes, we had this question, 30-year-old male presents with non-axial proptosis of the left eye. Patient gives a history of RTA 15 years back. CT MRI image is given. What is the likely diagnosis? Yes, it is. We can see mucocele of the frontal sinus. Now also in the frontal sinus, there can be subperiosteal abscess. We can see that the frontal sinus, yes, so frontal sinusitis can lead to subperiosteal abscess just in front of the frontal sinus in the forehead area, which can present as a soft doughy swelling in the forehead area. This is what is known as Pott's puffy tumor. So this follows osteomyelitis of the frontal sinus, which follows a frontal sinusitis. Yes, so this CT was a spot diagnosis of your exam. What are you seeing here? Yes, we can see that in this CT there is a mass that we can see in the ethmoid sinuses, in the maxillary sinus also, and this has a typical double density appearance. Yes, it has a heterogeneous appearance which is highly diagnostic of fungal sinusitis. Whether it is fungal ball or it is allergic fungal sinusitis, in both we will see the heterogeneous appearance because the fungus has a special affinity for metals, giving it this double density sign. So was asked in your exam, what is the sign seen? This is double density sign, right? And along with this on CT, if you are seeing mucinous secretions, right, mucinous discharge and nasal polyps, then this is allergic fungal sinusitis. Yes, in allergic fungal sinusitis, patient is immunocompetent, but he is highly allergic to the fungus, leading to a lot of eosinophils in the secretions that make the secretions mucinous. And also this allergic edema in the middle meatal area chronically leads to the polyp formation, right? So for the diagnosis of allergic fungal sinusitis, there are the major criteria of Bent and Kuhn. There are 5 major criteria, out of which we already have seen 3. What is? Yes, one is the CT finding, double density. 2 is the nasal polyp. 3 is the mucinous secretion. 4 is, I told you this is an allergic patient, so IgE levels raised. And 5 is when you take the nasal smear, yes, the fungal smear is positive. Fungal smear. Yes, was a question of your exam where the incorrect choice for major criteria was fungal culture. Yes, smear is major criteria, culture is a minor criteria. We need to know the major criteria, that is sufficient. Yes, what is this? We can see the blackish discoloration of the turbinate, of the skin, of the palate. Yes, so this is the typical appearance of the angioinvasive fungus which is seen in immunocompromised. Yes, it can be either mucormycosis or invasive aspergillosis. Both are angioinvasive, because of which they cause thrombosis inside the vessel that leads to necrotic tissues all around it, and this black that you are seeing is ischemia and necrosis. So if when you take the nasal scrapings for microscopy and biopsy, if what you see is a septate hyphae branching at right angle, then this is the typical appearance of mucormycosis. Yes, this was what was asked in your exam. This picture exact was given. Whereas if what you are seeing is a septate hyphae branching at right angle, then that is aspergillus. The management is different, so we need to know which one of this is it. If it is mucormycosis, then you immediately start the patient on IV amphotericin B. Whereas in invasive aspergillosis, you give voriconazole. Yes, you manage the immunocompromised status, and you also do a good surgical debridement in both these conditions. Yes, again a question this year. A patient underwent surgery for nasal obstruction, now presents with crusting. Endoscopic picture is given. What surgery was done? So what are we seeing here? Yes, anterior rhinoscopy is being done, and we are seeing this here is the septum on which you can see the perforation. So yes, whenever you are seeing a perforation on the septum, what do you have to think? Yes, the most common cause of septal perforation is trauma, and that is usually surgery. Which surgery on the septum can lead to septal perforation? Yes, SMR. And if no history of surgery, then the next thing that you have to think of is granulomatous conditions. And in granulomatous conditions, all cause perforation of the septum in the cartilaginous part, except for syphilis and vaginous. They also cause bony perforation along with cartilaginous, and in syphilis, most common perforation is bony. Yes, so what procedure is being done here? Yes, this is how a closed reduction of the fracture of nasal bone is done. So in closed reduction, we use two types of forceps. One is for reducing the nasal bone and the other is for septum. So tell me which one will be for bone, which one will be for septum. One is for what and two is for what? Yes, so remember, for septum, the blades of the forceps is longer also, and it is curved also, because we have to go down, hold the septum and reduce it. Whereas for bone, the bone is only upper 1/3. So then the blades will be shorter, it will be flatter. So the one which is for bone, it is named as bony wall, so that is Walsham. And for septum is known as ashes. So this is ashes 2, one is Walsham. So reduction of the nasal fracture, nasal bone is done. Closed reduction is the management, and that is done once the edema has subsided, that is after 5 to 7 days. But if the patient has presented any time after 2 to 3 weeks, callus formation occurs, bony fusion occurs, and then we will not be able to do closed reduction, then the management is open reduction. And open reduction is what is known as rhinoplasty. It can be only rhinoplasty or along with septoplasty, septorhinoplasty. Now, when you are doing a rhinoplasty, where will you get the incision? Rhinoplasty is, yes, it is a cosmetic surgery. To correct the external deformity of the nose, we will definitely not want an incision on the external nose. So, then the incision will be usually either a columellar incision, as you are seeing here. Yes, this is the hidden incision, and it heals very beautifully, the scar is not visible. Or it can be a rim incision inside, or it can be an incision inside the nose, inside the nose, in between the upper and lower lateral cartilage, that is the Lyman nasi area. Yes, in between the upper lateral and the lower lateral cartilage. So what is done is, incision is given, the skin is raised from above the bony framework, and then whatever you want to do on the framework, reduce it, correct it, everything is done. That is what is rhinoplasty. So yes, it is always done after 17 years of age. And this was a question this year. Nasal surgery was done in this patient and the incision mark is shown. Which of these was probably done? So yes, what surgery was being done here? This is for rhinoplasty. Now can you tell me what is the incision for septoplasty? Yes, for septoplasty, the incision is on the septum. For septoplasty, the incision is at the caudal border. This is what is known as the Freer's incision, also known as hemitransfixion. Whereas for SMR, the incision is 1 centimeter above the lower border of the septum, and this is known as Killian's. How do you remember? In Killian's, you are killing the septum, you are removing most of the septum. Yes, what is this surgery? The second picture. Yes, you are removing, except for a L-shaped strip, you are removing the whole of the septum. This is, you are killing the septum, that the incision is Killian's incision. Whereas in Freer's, that is what you do for septoplasty, you are freeing the septum of its deviation, so it is Freer's incision, right? Remember it like that. Yes, what is this one picture? Yes, you are giving a sublabial incision and you are making an opening on the interior wall of the maxillary antrum. This is to approach the maxillary sinus or the area behind the maxillary sinus, the sphenopalatine fossa. This is, yes, this is Cadwell Luck. Cadwell lug. And what is the second? Yes, here you are giving a sublabial incision from one molar to the other, raising the skin complete. This is what is known as midfacial degloving. Midfacial degloving is done to expose the complete maxillary sinuses whenever you want to remove tumors of maxillary sinuses or for angiofibroma. Yes, so this is a very important CT that is repeatedly asked. What are you seeing? We are seeing that the floor of the orbit has ruptured and the orbital fat is protruding into the maxillary sinus like a drop of tear. This is known as teardrop sign. Teardrop sign, and this is seen in, yes, this is seen in blowout fracture of the orbit, blowout fracture. Yes, again was a question, blowout fracture is fracture of which wall of the orbit? Yes, it is a fracture of inferior wall fracture. Which procedure is shown in the following figure? So yes, a favorite of your exam nowadays, the anesthesia of the nose. So for that we need to know what the sensory nerve supply of the nose is. Yes, it is by the two branches of the trigeminal, the ophthalmic and the maxillary. Yes, let us see first ophthalmic. Ophthalmic, as the name, it enters the eye through, yes, so it does not enter the eye, it gives branches which enter the eye. Which branches? Yes, the lacrimal, the frontal and the nasociliary, and they enter the eye through the superior orbital fissure. In fact, this year was this picture given and was marked this fissure and was asked that when there is compression of nerves of this fissure, where will be the anesthesia? Yes, so the same thing we are asking in different ways. So yes, now the lacrimal, frontal and nasociliary, out of which the, yes, the nasociliary is the one that will supply the nose. Yes, it has ciliary branches also. Now the nasociliary will give posterior ethmoidal branch and then the anterior ethmoidal, and then it will come here on the dorsum and it will enter as infratrochlear, right? Now this anterior and posterior ethmoidal will pierce the lamina papyracea through the same name foramen, anterior and posterior ethmoidal foramen. They will enter inside the nose and give some supply to the nose. Now the anterior ethmoidal, where it enters inside, it gives the internal nasal branch and it gives a branch that pierces in between the nasal bone and the upper lateral cartilage to come on the external surface like this. That is known as external nasal. Right. So if we talk about the external nose, the whole of the midline of the dorsum of the external nose is by nasociliary, the upper part is by infratrochlear, the lower part is by external nasal. Is that very clear? Yes, so from the ophthalmic we have the nasociliary which gives the anterior ethmoidal, the posterior ethmoidal and the intratrochlear. The anterior ethmoidal again divides into internal and external nasal, and what do they supply? They supply the root and dorsum up till the tip of external nose. Right. So if we have to anesthetize the dorsum of the external nose, how can we anesthetize it? See very carefully, right? Now here if I have to anesthetize the upper part, I will have to anesthetize the intratrochlear, for which I will give the anesthesia medial to the eyebrow, right? We have the eyebrow, medial to the eyebrow, that will be intratrochlear. Now if I have to anesthetize the external nasal, I will anesthetize it here. If I have to anesthetize the nasociliary or the anterior ethmoidal, yes, above the medial canthus, 1 centimeter above it, which means that this area will be a little lateral to the area of intratrochlear. Is that clear? Okay, so I will inject the anesthetic from here around 1.5 centimeters deep. When I go, that will be the anterior ethmoidal. Further 1 centimeter deep will be posterior ethmoidal. Now let us see this. Yes, so tell me which nerve is being anesthetized? Yes, at the medial end of the brow, this is intratrochlear. Very good. External nasal, 1 centimeter, yes, above the medial canthus, and deep to that, yes, that is the nasociliary, right? Now the second branch of the trigeminal is the maxillary. Now how does maxillary enter the nose? The maxillary exits the cranium through, yes, you will tell me, yes, through the foramen rotundum. So this foramen that we are seeing is the foramen rotundum. We are seeing another foramen here at the root of the pterygoid plates. This is the Vedian canal. It is also known as the pterygoid canal. Okay. So from the foramen rotundum, the maxillary will exit the cranium, and the moment it exits the cranium, here we have the foramen rotundum, through which it will exit the cranium, directly enter into this space in between the maxillary sinus anteriorly and the pterygoid plate posteriorly. This is known as the sphenopalatine fossa. Now once the maxillary nerve has come into the sphenopalatine fossa, it will give sensory branches to the orbit, to the maxillary sinuses, to the palate, the greater and lesser palatine nerves, and also to the nose. The branches to the nose will enter through the sphenopalatine foramen 1 centimeter behind the middle turbinate, and they will come to supply the nose. Now also the maxillary, after supplying this through the inferior orbital intraorbital canal, yes, it passes and it comes out through a foramen here. Can you see here? Through the infraorbital foramen, and now it gives a sensory nerve supply to the skin of the cheek and also to the ala of the nose, which means that if we want to anesthetize this area, we will have to anesthetize the intraorbital nerve. And if we want to anesthetize the sphenopalatine, the main branches of the maxillary nerve which gives sensory nerve supply to the nose, the sphenopalatine nerves, then we will have to anesthetize it at the sphenopalatine foramen area. That is done like this as shown in the first picture. And if we have to anesthetize the infraorbital nerve, yes, we can anesthetize it externally like this, or through sublabially. We can just feel this foramen and we can anesthetize it like that, right? So now can you tell me which procedure is shown in the first? Yes, see carefully. Yes, this is intratrochlear, and in the second it is a little more lateral. That is the nasociliary. If nasociliary is not there in the choice, we will mark anterior ethmoidal. If both anterior ethmoidal and nasociliary is in the choice, better answer will be nasociliary. Yes, again another question last year. Which foramen is this? Yes, this is the foramen rotundum, and which foramen is this? The pterygoid foramen or the Vedian canal, Vedian foramen. Now again this identify the mark structure. What is the mark structure? We can see that there is, yes, some protrusion that we are seeing in the lamina papyracea through which a mesentery is going to the septum. So yes, when the along with the nerves enter the artery, which artery? A branch of the ophthalmic artery. Ophthalmic artery, as the name, enters the eye through the optic canal. Here it gives the posterior ethmoidal and the anterior ethmoidal arteries. The anterior ethmoidal artery, while it pierces the lamina papyracea to enter into the nose, it produces a notch like this, a prominence like this. This is what is known as the anterior ethmoidal notch, or it is known as nipple sign. Nipple sign. So then it gives some branches to the lateral wall, runs to the cribriform plate, and then gives some branches to the nasal septum. So what is this mark structure? This is known as anterior ethmoidal notch. Anterior ethmoidal notch. Yes, so what is this? The patient keeps running the nose in allergic rhinitis, and that results in a transverse crease on the external nose known as allergic salute. A South Indian male cattle breeder presents to the OPD with epistaxis, examination of the nose shown below, biopsy, histopathology shown. So yes, what we are seeing in the nose? Strawberry mulberry mass, and the histopathology is showing lots of sporangium which are filled with sporangiospores. Yes, this is a typical appearance of rhinosporidiosis. Rhinosporidiosis caused by protozoa Rhinosporidium seaberi, which the patient acquires by taking bath in ponds frequented by animals, that is by cattle breeder. A 70-year-old male presented with nasal obstruction, blood tinged nasal discharge, biopsy and CT scan is shown below. So, whenever it is any elderly with blood tinged nasal discharge, what should come to your mind? A tumor. Yes, it can be the most common benign tumor of the nasal cavity, that is inverted papilloma, or it can be a carcinoma. Now, usually whenever they ask for carcinoma of the paranasal sinuses, usually they mention the carpenter or wood exposure something, yes. So, by the history, we can make out that maybe it is the benign tumor inverted papilloma. Let us see what the biopsy. Yes, the biopsy is showing the epithelium, instead of growing towards the outside, is growing towards the stroma inside. And what is the CT showing? Yes, the CT here will show inside the nose, the endoscopy will just show papillary appearance, polypoidal mass from the middle meatus. Yes, this arises from the lateral wall. So, that is again that is asked. And what you see on the CT, see carefully, you are seeing some appearance which is not appearing homogeneous. So, yes, this inverted papilloma typically has a cerebriform appearance, which means that there are alternating lines of high signal intensity and low signal intensity, and that is the typical appearance. You will see that on the CT, yes, exactly, you might not be able to see the cerebriform appearance, but you will be able to make out that it is high density, low density, high density, low density, it is not uniform. So, yes, this is how the inverted papilloma, also known as Ringer's papilloma, Ringer's tumor looks like. So, what is this line? Yes, this is what is the Ongren's line. Yes, this divides the maxillary sinus into an infrastructure and a suprastructure. So, this is a classification for maxillary tumors, that the infrastructure tumors have better prognosis as compared to the suprastructure, because suprastructure can go to the orbit, it can go intracranially, so that has poorer prognosis. Yes, a young pubertal male, again a favorite of your exam, young pubertal male with unilateral nasal obstruction and recurrent epistaxis. Any 15-year-old male, 20-year-old male, recurrent epistaxis. What do you have to think? Yes, you have to think of angiofibroma. Repeatedly, whenever this question is asked, this picture is given of the endoscopy showing the red fleshy mass. Yes, and what is asked is either the diagnosis or is asked what is the appearance of face of this patient. Yes, so the appearance of the face with broadening of nose, proptosis, swelling of cheek, that is what is known as the frog facies, right? And or what is asked is what is the best investigation. So, what's the best investigation? Yes, best investigation here is CECT. What you find on CECT, yes, you should be able to identify. What we are seeing here is a transverse cut section. This is the skin of the cheek, this is the nose, this is the skin of the cheek. The nasal cavities, yes, this is the area of the sphenopalatine foramen. Just see it on the opposite side. It is so narrow, here it is so widened. And we can see the enhancing mass in the nasal cavity, nasopharynx, in the sphenopalatine foramen, the sphenopalatine fossa, going further laterally into the infratemporal fossa, right. So, this pushing by the mass of the posterior wall of maxillary antrum anteriorly is what is known as the antral sign, also known as Hallman-Miller sign. Hallman-Miller sign. Yes. Now, see this and tell me what comes to your mind. Tell me the spot diagnosis. Yes, definitely never the spot diagnosis will be asked like that. A presentation will be given. So, tell me what the presentation will be. Yes, it will be a patient with pain in the throat, sore throat, otinophagia, difficulty in swallowing, hot potato voice. Yes, tell me the diagnosis. What you are seeing is that the tonsil is pushed medially, pushing the uvula to the opposite side. So, yes, the diagnosis is peritonsillar abscess. Now, let me add one word to the question along with everything that I told you. Now, when you examine, you are also seeing a bulge at the angle of jaw or at the upper border of sternocleidomastoid. Now, the diagnosis changes to a parapharyngeal abscess, right? So that is how you differentiate a peritonsil abscess that is squinsy from a anterior compartment parapharyngeal abscess. In both the presentation will be fever, sore throat, rhinophagia, pain in the ear. Pain in the ear from tonsillar area will be through which nerve? And that was a question, yes, that is through the ninth nerve, glossopharyngeal. Tonsils pushed medially and trismus. They will be seen, all these will be seen in both in peritonsil as well as parapharyngeal anterior compartment, but bulge at the angle of jaw because the parapharyngeal space extends in the hyoid. So, the bulge at the angle of jaw indicates that that is a parapharyngeal abscess. Okay. So, now yes, this was again a spot diagnosis. Recently asked, what are you seeing here? We are seeing through one of the nostril the nasopharynx, where we are seeing this is the lateral wall and this is the posterior wall. So, what are the structures in the lateral wall of nasopharynx that we see? I will mark 1, 2, 3, 4. You tell me what you are seeing. So, 1, what is 1? Very good, eustachian tube. 2 is torus tubaris. And what is 3? 3 is the area that is marked. What is that? That is the fossa of Rosenmuller, and that is the most common site of origin of nasopharyngeal carcinoma. Nasopharyngeal carcinoma. Yes, and here in the posterior pharyngeal wall, this is the area of the adenoids. Below is the picture of an 8-year-old child who came to the OPD with the complaints of mouth breathing, crowding of teeth as shown, appearance of face is known as. So, here is a child, mouth breathing, crowding of teeth, which means that the nose is obstructed. Yes, this is nasal obstruction. Mouth breathing typically seen in hypertrophied adenoid. This is known as adenoid facies. Adenoid facies. Another spot diagnosis. What is this? Yes, this is the Rose's position. What we do here is that we do extension at the cervicothoracic joint by placing a sandbag below the shoulders. So, there is extension at the cervicothoracic as well as at the atlanto-occipital joint. This is done because we want the neck, the trachea at a prominent position. So, this is done for tracheostomy, and we want this area to be down. Why? Because whenever we are doing adenoidectomy or tonsillectomy, we do not want the aspiration of the blood or the patient swallowing the blood, because bleeding is a very important complication during these surgeries. So, we do this Rose's position for tonsillectomy, adenoidectomy and tracheostomy. Now, if we remove the sandbag from below the shoulders, right? So, then it becomes flexion at the cervicothoracic joint and extension at atlanto-occipital joint. This becomes, from Rose's, it becomes the boy's position. Boy's position is also known as Chevalier-Jackson position, Chevalier-Jackson, or it is known as barking dog, or it is known as sniffing the morning air. Sniffing the morning air. Yes, for sniffing, it is flexion at the cervical, extension at atlanto-occipital joint, and this is the position whenever we operate on the larynx, whenever we do a microlaryngeal surgery, also whenever we do a direct laryngoscopy. So, while doing direct laryngoscopy, yes, that by direct laryngoscopy you also do intubation. So, that is also the position for intubation. This was a question this year when one of the choices was, this is the position for intubation, boy's position for intubation. Yes, so this is boy's position for direct laryngoscopy, intubation or MLS. Yes, a very important question. 12-year-old unimmunized child with sore throat, fever, pain in the throat, and what we are seeing is throat examination reveals a membrane over tonsil which bleeds on removal. So, this much history, we do not need any picture. Unimmunized child, membrane over tonsil which bleeds on removal tells you it is, yes, diphtheria. So, what is the typical appearance of diphtheritic membrane? Yes, it bleeds on removal. Why? Because it is tightly adherent to the underlying tissues, and also as you can see here, it will extend beyond the tonsillar fossa. And these patients are unimmunized, and also the neck has a typical swollen appearance, which is known as the bull neck appearance, and immediately you need to take a throat swab, which you will send for microscopy, where you will see the Chinese letter pattern, yes, the Corynebacterium diphtheriae, and you immediately give antitoxin against, what is the toxin here? Is it an endo or exotoxin? Yes, the exotoxin. So this is diphtheria. Yes, this is again a very repeated question. Name the structure marked in the figure. So what we are seeing is the larynx, and the structure that is marked is behind the larynx. So what lies behind the larynx? The laryngopharynx, the hypopharynx. So what are the parts of the hypopharynx? Yes, we have the three P's, the postcricoid, the piriform fossa, and we have the posterior pharyngeal wall. So what structure is marked? Yes, the piriform fossa has been marked. Yes, this is the piriform fossa. Can you tell me that what is the most common site of lodgement of foreign body in the hypopharynx? Yes, it is piriform fossa. And in the piriform fossa runs the internal laryngeal nerve very superficially. So carcinomas of piriform fossa can have pain in the ear because of which nerve? Internal laryngeal nerve. Yes, the vagus nerve. And also piriform fossa is very rich in lymphatics. It drains into upper deep cervical and middle deep cervical lymph node. So piriform fossa carcinomas can present very early with lymph nodes. Yes. What is this? Yes, we are seeing the lateral view X-ray. The moment we see this X-ray, we don't want to read the question because the X-ray we know very nicely. What is this? We are seeing the epiglottis is so swollen. Yes, usually the appearance of epiglottis is leaf shaped, but here it is swollen, appearing swollen like a thumb. This is thumb sign. This is diagnostic of, yes, of acute epiglottitis. Acute epiglottitis. I have told you the diagnosis. You tell me what will this question look like? What will be the presenting feature? Yes, here because of the swollen epiglottis, will the patient have stridor? Yes, what will be the stridor? Inspiratory. Whenever the obstruction is supraglottic, it is inspiratory stridor. And also see the epiglottis here. Whenever this patient will lie supine, what will happen? The swollen epiglottis will further block the larynx and the stridor will increase. That is why this patient will always prefer this position. This is bending down, or this is known as the tripod position, right? The tripod position. And also when this patient will lie in front prone, all this swollen epiglottis will fall in front and the stridor will disappear. And very, very important finding, this patient will have drooling of saliva. Why? Because this swollen epiglottis, whenever it falls down to close the inlet of the larynx during swallowing, patient will have very severe pain. So these findings, yes, will tell you it is acute epiglottitis. And this again, this was a spot diagnosis this year. This is the typical pencil tip sign, or it is all known as the steeple sign, seen in, quickly tell me, laryngotracheobronchitis, that is croup. Yes, in croup, what is the typical cough? Will there be hoarseness also? Yes, this is a viral infection caused by parainfluenza. It involves the whole of the larynx. There will be hoarseness. There will be cough, that is known as the seal-like or the barking cough. And the stridor here to start with inspiratory, but later on mainly because of the involvement of subglottis, it becomes biphasic. Biphasic stridor. Yes, so again a question this year, patient with history of prolonged intubation presents with breathlessness, following is seen on laryngoscopy. So what are you seeing here? Again, there is a spot diagnosis. You are seeing the vocal cords. Below that, in the subglottic area, we can see that the lumen is so narrowed. So yes, this is subglottic stenosis. Yes, the subglottic stenosis can be congenital, but the most common acquired cause is prolonged intubation. And what is asked here is the staging for this is given by. So the staging here is given by, yes, the Cotton-Mayer classification. Cotton-Mayer classification. Yes, a 55-year-old patient comes with a hoarseness of voice, difficulty in swallowing, difficulty in breathing. The patient was diagnosed with cancer. Surgical management was done. Post-operative picture is given below. Which surgery was done in the patient? Yes, the same thing they keep asking repeatedly in different ways. So this is a patient of carcinoma of the larynx. Which surgery have you done? What are you seeing here in the picture? We are seeing that there is an opening here. What is this known as? This is known as permanent tracheostome. What do you do in carcinoma larynx? You remove the larynx. So the trachea that is left below, you pull it out and you suture it to the skin. So you make a permanent opening on the skin outside. So whenever in carcinoma larynx patient you see opening like this post surgery, it means what surgery has been done? A total laryngectomy has been done for this patient. Is that clear? In the choice was also given tracheostomy. How does a patient of tracheostomy look like? Yes, for tracheostomy you will see the tracheostomy tube. On the neck, you will not see just an opening like this. Yes, so when you do a tracheostomy, immediately you put a tube which has a cuff. So cuffed tube you put so that if there is bleeding, aspiration does not occur. And this is how the cuffed tube looks like. This was asked as a picture-based diagnosis, image-based spot diagnosis. And also after 3 days, you change it to an uncuffed tube. This is how the uncuffed tubes looks like. So yes, when you are seeing an opening like this, post cancer surgery of the larynx, this is permanent tracheostome, and it means that what surgery you have done is total laryngectomy. Now following laryngectomy, when we have removed the vocal cords, we have to give speech rehabilitation to the patient. That we can give by esophageal speech, or we can give by putting a prosthesis here. This is what is known as tracheoesophageal speech. So what we do here is, while surgery itself, this trachea that we have pulled out and sutured it to the skin here, we make an opening here on which we put a valve, and this valve is known as Blom-Singer, or it can be Panji valve. So whenever the patient now during expiration, he will keep his hand here, his finger here. So all the air from here will go through this valve into the hypopharyngeal segment, that is known as pharyngoesophageal segment. Pharyngoesophageal segment that is present behind the larynx, and the vibration of that segment will lead to production of voice. So this is a lung powered air that is going to the pharyngoesophageal segment. So the speech that is produced is lung powered. This is the best form of speech. The other form of speech that these patients can have is with the help of electrolarynx, where the patient uses this device to produce vibrations of the pharyngoesophageal segment from the outside. And can you also notice in this patient this? What is this? Tell me. Now you tell me what this is. Yes, this is permanent tracheostome. Means what surgery has been done? Total laryngectomy. You have pulled out the trachea, sutured it to the skin outside. Yes, so if you can see that on the permanent tracheostome, this device, what is this? Yes, this patient is breathing from here now. He is not breathing through the nose. And the function of the nose is temperature regulation, humidification. So which means that if he will not use this device, there will be drying, crusting, repeated infection of the airways. So this is the heat and moisture exchanger. When the air passes to this, it gets humidified. What is the radiological staging of this patient with laryngeal carcinoma? Yes, whenever there is a radiological staging that is asked from you, definitely what will be expected from you will be to identify only the complete erosion of the cartilage, right? So yes, this is a transverse cut section where we are seeing this is the thyroid, this is the arytenoid, this is the lumen of the larynx that we are seeing, and what we are seeing here is that in the lumen there is extension of this growth. The other side, the arytenoid, is completely eroded. Even there is a through and through erosion of the thyroid cartilage. So what stage is that? When there is complete erosion of the cartilage, it is T4. And which is the best investigation for seeing the cartilage invasion? Is it CT or MRI? Always for cartilage, it is MRI. So again, that is another question of your exam. Yes. So nowadays, of late, for the past few years, repeatedly this question is asked that whenever you are seeing a round foreign body, how do you know that this is in the larynx or whether it is in the esophagus. So always remember that the longest diameter, long axis of the larynx is maximum in the anteroposterior area. So whenever a coin or a round foreign body gets stuck here, it will get stuck like this, which means on AP view, this foreign body will appear rim-like when you see in the AP view, and in lateral view, you will see it round. Whereas if it gets stuck in the esophagus, the longest diameter is the horizontal diameter in the esophagus. So the foreign body will get stuck like this. On AP view, it will appear round, and on lateral view, it will appear rim-like. So yes, what we are seeing here is that on the AP view, it is a rim, and on the lateral view, you are seeing the complete circle, which means it has got stuck like this. So it is in the larynx. And also please note here, in the second picture, you can clearly see that we have the laryngeal airway inside which we are seeing the foreign body. So now can you see the foreign body? Where is it? Yes, on the AP view, you are seeing the round, which means it has got stuck like this. So yes, it is in the esophagus. On the lateral view, it is the rim-like. So now it is in the esophagus. Yes, and also we need to remember that the most common site of lodgement of coin in the esophagus is just below, at and just below the cricopharyngeal sphincter. Yes, so what is this foreign body? Is it coin? Yes, see carefully that it is not a homogeneous, it is appearing like double ring. Yes, so this is known as a double ring appearance, or it is known as halo appearance, and this is the typical appearance that you see in battery. Yes, the battery foreign body, as you can see, it will appear like two rim, and also on the lateral view, it will appear bi-leveled. It will appear like a step off at the edge. At the edge, there is like a step off. Yes, so this is typical appearance of battery. And whenever you see any question which mentions that child or adult is suddenly started choking, gagging or coughing, it means that there is foreign body. So what is this maneuver that is shown? Yes, this was a picture based question of your exam. So yes, what they are showing is the Heimlich maneuver. You should know when you will do it. Yes, for this the patient should be conscious first, it should be conscious, and second, the universal choking sign should be present. What is universal choking sign? The patient is holding his throat like this and his not able to either cough, breathe or speak. Nothing is possible. Then you do this Heimlich maneuver where you give thrust just below the sternum. It is also known as abdominal thrust. In children who are less than 1 year, in pregnant and in obese, you do not do this maneuver. In them you go for chest thrust. Now, as we approach to the end of this session, I have a quick quiz for you where I have kept 12 spotters for you. So, let us see if you are able to identify them or not. Yes, so sit straight. Ready? Yes, you are going to tell me your score at the end, right? Okay, so let us start with this quiz. The first question we have here is, yes, identify. Very good. What is this? Yes, this is pre-auricular sinus. This is the fusion defect of the auricular tubercles of the first and second arch. And the most common site, as we are seeing here, is the root of the helix. So the next question, identify the mark structure. So yes, tell me what is the answer. What are you seeing here? Yes, this is, we can make out it is internal acoustic meatus. What is marked is in the superior part. Tell me what is this? Facial, superior vestibular, inferior vestibular or the cochlear. Yes, the first thing we can very easily make out is this round. What is this? Yes, we know this is the cochlear, that is the 8th nerve. Just above that we will have the 7th nerve. 7th is earlier. It will be above, and we also remember that by 7 up. And adjacent to that, this will be the vestibular. It is in the superior part, so superior vestibular, and this will be inferior vestibular. So what is the answer here? Yes, this is the facial. And now if I mark this, what is this? Yes, this is the bar of bone, the Bill's bar. Bill's bar. Bill's bar. And along with the inferior vestibular nerve, there is a branch of the inferior vestibular singular nerve which also enters through the inferior foramen. So the next question, identify. Yes, what test is this? Very good. This is the Cotter's test, and this is a test for nasal valve patency. The next question, identify the fracture in the given diagram, and we have 1 and 2. Tell me what is 1 and what is 2? 1 is? Yes, one is a vertical fracture, two is a horizontal fracture. Vertical is like 1. So that is the shiveler fracture. C comes earlier, J comes later. So C is 1, J is 2, and 1 tells us that 1 is vertical. 1 looks like vertical, so this is vertical. Yes, so this is the shiveler and this is the gingiva. Could you make it correct? Next question, identify. Yes, what is this? The bulky external nose. Very good, that is the potato nose rhinophyma, also known as nasal elephantiasis, and this is because of the hypertrophy of sebaceous glands of the tip of nose seen in middle age or old age men, and usually with a history of acne rosacea. So the next question, yes, identify, what is this? Very good, this is Ludwig's angina. What is Ludwig's angina? Is it cellulitis or abscess? Cellulitis of submandibular space, unilateral, bilateral? Bilateral. Yes, so Ludwig's angina is a cellulitis of bilateral submandibular space, and submandibular space is divided by the mylohyoid into above is the sublingual compartment and below is the submaxillary or the submandibular compartment. In the first picture, we are seeing mainly the external involvement, that is of the submandibular compartment, and in the second picture here, we are seeing mainly the sublingual involvement where we are seeing the raised floor of mouth. So yes, this is Ludwig's angina. Yes, identify. Yes, okay, I try to identify first the first picture and then we will go on to the second picture. Yes, they are given in conjugation. So both of them will help you to make the diagnosis. Yes, very good. What we are seeing in the first picture is that the prevertebral shadow is increased. Also, there is straightening of the spine. Retropharyngeal abscess or prevertebral abscess. Yes, this X-ray will tell us that there is some abscess behind the posterior pharyngeal wall, but whether it is retropharyngeal or prevertebral, that you cannot come to know just by this X-ray. Then how do you come to know? Yes, either by the history that is given, the examination finding that is given, or by the next picture, which is the transverse cut section that we are seeing here, the CT. Yes, so yes, we always remember that the retropharyngeal space is divided in the midline by a fibrous referent of 2 spaces, whereas the prevertebral space is it's not divided in the midline, which means that any mass or any abscess of the retropharyngeal space will be a unilateral paramedian bulge on the posterior pharyngeal wall. In the posterior pharyngeal wall, there is a bulge, but only unilaterally on one side of midline, whereas a prevertebral abscess will be a midline diffuse bulge of the posterior pharyngeal wall. So yes, let us see the second picture. Here we are seeing a transverse cut section. This is the cheek, the nose, the nasal cavity, and here we are seeing the pharyngeal lumen, in which we are seeing that yes, there is a bulge only on one side of the midline. So yes, this is the retropharyngeal abscess. And also something very easy to remember to make out whether the prevertebral shadow is increased or not is, in this picture it is very obvious, but sometimes you are doubting that whether the prevertebral shadow is increased or not. So in those cases, a very quick guide to tell you whether it is normal prevertebral shadow or not is that always see that in the upper part of the cervical vertebrae, that is from C1 to C3, the prevertebral shadow should never be more than half of the width of the vertebral body, right? If it is more than half of the width, it means it is abnormal. And from below C3, that is from C4 to T1, the width of the prevertebral shadow should not be more than the entire width of the vertebral body. So if it is less than the entire width of the vertebral body, that is this much, then it means it is normal. If it is more than that, it means that the prevertebral shadow is increased, suggesting that there is some abscess of either retropharyngeal or the prevertebral space. Yes, the next question. Yes, very good. This is a spot diagnosis. This is the barium swallow showing this outpouching in the upper part of the esophagus. That is, yes, that is the pharyngeal pouch, the Zenker's diverticulum arising from Killian's dehiscence, that is in between the thyropharyngeus and the cricopharyngeus part of inferior constrictor. Yes, it is the posterior pouch, later on becomes lateral, so it is posterolateral. And on endoscopy, what you see is this is the esophageal lumen and you see the separate pouch here. Yes, arises from tibial dehiscence, which is also known as gateway of tears. Next. Yes, identify what are you seeing? What is this? Is this grommet? No. Then what is this? Yes, we have seen this being used earlier. Yes, this is a patient of laryngectomy. Why? Because we are seeing this opening. This is known as a permanent tracheostome, where you can see this valve. And we are seeing this one end of the valve, and the entire valve looks like this. This is known as the tracheoesophageal valve, also known as voice prosthesis. This is the Blom-Singer valve that we use for tracheoesophageal speech. Yes? Could you make it right? So the next question, yes, so we have two spotters here, 1 and 2. What are we seeing? Yes, without doubt we are seeing the vocal cords. What are we seeing in 1? We are seeing some bilateral swelling in the vocal cord, which is the anterior and which is the posterior part of the vocal cord. Yes, we know that where the vocal cords meet, that is the anterior part, and the other is the posterior part. So at the junction of anterior 1/3 and the posterior 2/3, here we are seeing bilateral swellings, and in the second picture we are seeing a unilateral big swelling. So yes, one is vocal nodule, which are bilaterally symmetrical, less than 3 millimeters, whereas in 2 what we are seeing is vocal polyp, which is solitary and it is huge. It is more than 3 millimeters. And yes, the site is the same, junction of anterior 1/3 and posterior 2/3. Next question, yes, diagnose. Yes, this is laryngomalacia. What we are seeing here is the enlarged omega-shaped epiglottis, short AE folds, prominent arytenoid. So this is the most common congenital anomaly of the larynx, also known as congenital laryngeal stridor. And these findings that I just told you, along with excessive redundant tissue of the supraglottis, are the diagnostic features that we find on laryngoscopy to diagnose this condition. Yes, identify. Very good. This is the Boyce-Davis mouth gag, and it is used for opening the mouth whenever we want to go for adenoidectomy, tonsillectomy, or whenever we want to operate on the palate or the nasopharynx. Yes, so tell me, out of the 12 questions, how many could you make correct? What is the score? Very good. So that brings us to the end of this session. Yes, always remember that the most beautiful thing about learning is that nobody can take it away from you. So just believe in yourself, give your best, and do not think about anything of the past or the future. You will definitely succeed. All the best. God bless you.